Good evening, everyone. This is Dr. Niranjan Chavan from Mumbai, your host for TOG webinar. And today we are having a wonderful time in North India. On behalf of Foxy Medical Disorders and Pregnancy Committee and 8 North Indian societies, I welcome you all to the Rh negative immunization in pregnancy and recurrent pregnancy loss and minimal invasive surgery webinar on 4th September 2020. I would like to thank Bharat Serum and Vaccines Limited to take this opportunity with the program Bridging Bharat, and that's why we are here, and the academic team of Science Integra to get us today. Welcome all of you. Good evening, everyone. Now I would like to introduce our chief guest today, and this is none other than Dr. Usha Sharma Padma Shri. Madam, welcome. Thank you so much for visiting today and gracing this occasion with your esteemed presence in the webinar. We have to thank you on this behalf. We want to know also and tell everyone that you are a Padma Shri given this medal by the President of India, and you were also the ex-director medical education of the Uttar Pradesh and principal cum professor of gynecology and obstetrics, Medical College Meerut. You were also the society president of Meerut from 78 to 2008, and a lot of awards, madam, you have got. Thank you so much for being there and gracing this occasion and as the chief guest. Next slide, please. I call upon our guest of honor, none other than from the city of Agra. We can say he is the king of Agra, or we can say he is a man or the father of ultrasound in India, and that's none other than Narendra Malhotra sir. An inspiration beyond comparison. A guy who is an encyclopedia, multitasking all the time. And that inspiration gives us the boost to work much more in Foxy. He's a professor at Dobrovenik International University, vice president of WAPM. We all know he has donned many hats, and it is very significantly to be noted that he was our Foxy president, our ISAR, SAFOG, ISPAT, and also the member of the FIGO Guidelines Committee. He has got many awards and many publications to his credit. The most important thing I would like to tell you, sir, and everyone, that he is youngest at the heart and adds a lot of energy to every platform he joins. And that's what I can say. We all know he's a managing director of Global Rainbow Healthcare Agra. Welcome, sir. Now, I would like to also call our next guest of honor, none other than the lady who is a charismatic personality, an enigmatic one, the one who always inspires with her beautiful smile and her gracious esteemed presence, none other than Professor Dr. Meera Agnihotri, madam. We all know that GSVM Medical College of Kanpur is incomplete without her contribution, and it's very important that she has represented India on various forums in Foxy, in FIGO, and also as a visiting consultant at the Baylor College of Medicine at the Texas. And she's always organizing one or the other conferences in the bastion of Uttar Pradesh. And we are very, very happy to have here. Now I would request both of you, our guest of honor, to present us their inspirational words and guide us for this webinar. We are all coming today to North India. Thank you so much.
Ladies first, Meera ji. Ladies first, Meera ji. You start your program, it is enough. Our blessings are always with you. You start your program, don't get late.
No, so
Niranjan, you start your program, that is what I feel.
Yes.
So greetings to everyone who is attending this. It's a pan society meeting of so many 8 societies together, which is so good. Never could we believe or could we imagine that all of us will get together and interact face to face. So it's indeed a great thing that to get all together, and Niranjan, Bharti, and Science Integra for integrating everyone together. So it's indeed a pleasure. And of the topic RH isoimmunization, which we need to know what are the major RH, what is the minor RH, how much anti-D do they give, whether to repeat or not, how to calculate the blood mixing, so many things which I'm sure this webinar will clear. And it's indeed a great pleasure to be here amongst all of you. And I wish all the Foxy vice presidents all the best for this election which is happening. And I also wish Niranjan Shah all the best for his treasurer's election for IAG. So all the best to all of you.
Niranjan Chavan sir, please.
Niranjan Chauhan Shah nahi.
ट्रेजरर तो फॉक्सी का तो हो ही गया अनअपोज्ड.
Yes sir. Yes.
Yes, लगन treasurer बनना चाहता है मैडम.
Thank you madam all for your blessings. Usha Sharma ji, आप 2 शब्द बोलिए, then we will start with the program.
Thank you very much, Niranjan, for saying nice words about me. Dr. Meera Agnihotri, guest of honor. She is a very affectionate and lovely lady and has many academic achievements. Dr. Narendra Malhotra, he is just like my son. And Narendra, I think you must be the youngest past president. Are you not?
Kamini Rao and Sirish Sheth. I'm the third youngest.
Yes. But
I'm the third youngest. Kamini Rao was the youngest, and Sirish Sheth, and then I'm the third. ये लोग 40 साल की उम्र में ही बन गए थे.
तो तुम नंबर 3 हो, ठीक है? And he is just like my son.
Hello.
तो जैसे लोग कहते हैं ना कि माँ को अपना बेटा बहुत प्यारा लगता है, पर यहाँ कुछ अलग है. मुझे बेटे से ज्यादा बहू प्यारी लगती है. मुझे जयदीप, I really admire her. And Naren, you are such a dynamic and dedicated person that I always appreciated. Dr. Niranjan, you are such a wonderful person. I can tell you, you are a great academician. You are Vice President, Mumbai Obstetric Gynec Society, and you are being elected Treasurer unopposed. Congratulations once again. Bharti Maheshwari, I can't say much about her because she is all the time with me in my heart, and she is such a dynamic and hard-working person. शायद ही कोई जगह इसने छोड़ी हो जहां इसने MTP Act, MTP forms और various methods of abortion ना बताए हो. Legal abortion or something. No doubt she has really worked very, very hard. She has been elected member of governing council of ICOG, and I'm sure that now she must consent for vice president of Foxy in 2021, and I wish her best of luck. And she will be telling us about RH isoimmunization, and Niranjan will be telling us a very important topic about RPL. He will have panel discussion. We have got experts with her, dear Rukma, कीर्ति एंड अभिलाषा. हर तरफ मुझे अपना मेरठ नजर आ रहा है. और आज की चेयरपर्सन डॉक्टर प्रियंका, जो मेरी बहुत ही डियर स्टूडेंट है. शी इज वेरी क्लोज टू माय हार्ट. नॉट ओनली प्रियंका बट अनुरीता also. Both of them are chairpersons today. All the special guests, worthy panelists, representatives from Bharat Serum and Vaccine Limited. Thank you very much, and it gives me great pleasure to be here along with you on the occasion of this CME, which has been organized under the banner of Medical Disorders in Pregnancy and Meerut Society. And we know that we have also been associated with Agra, Aligarh, Mathura, Noida, Greater Noida, Saharanpur, and Haridwar. Today we will be discussing two very important topics, RH isommunization as well as RPL. RH isommunization is potentially, as just now Narinder said, is a preventable condition usually associated with significant perinatal mortality and morbidity. Severity of the disease can be assessed using various methods, and usually invasive techniques are required to determine the disease. But Doppler flow studies appear to be very useful non-invasive procedure. To evaluate fetal risk, we should always use as a basic test Doppler flow studies, then only we go ahead. As regards RPL, it is one field in which I can say diagnosis and treatment is changing every day. Genetic analysis of products of conception with microarray has come up in recent times. Hence, updated knowledge of the subject and tender loving care is the key of the success. Both the topics are very important and we should listen to the speakers, and I'm sure that the deliberation today will be very, very fruitful for everyone who is attending this webinar. I wish this program a great success, and Niranjan, it's very good that you have organized this program with Meerut Society. I can tell you that our Meerut Society is very active and always ready to accept any challenge, whatever is given to it. With these words, I wish this webinar a great success and wish you all a very, very healthy, happy and bright future. Thank you once again for making me a part of such a wonderful webinar. Thank you very much.
Dr. Niranjan, before starting the science week program, I want to say something to all of you that Dr. Niranjan, they have organized this very good program. And Dr. Meera Agnihotri, madam, please unmute yourself. Actually, he wanted to organize this program and covering maximum societies and want to interact all of us. And Dr. Meera Agnihotri and Dr. Naren Malhotra, sir, you are really our esteemed guest of honor. And Meera Agnihotri, madam, we want to hear something about you, and especially on this topic. What is your experience and what you want to give message? Thank you all. Yes. Not audible, madam. You have to unmute.
Meera, unmute karo.
And thank you, Shama ma'am, for kind words. What you say always for me. Thank you. And now other experts are also has entered. Dr. Ukma madam and all. So Meera madam, please unmute yourself.
Is that right? Am I audible now?
Yes, madam. Yes, madam.
At the outset, I will say that I am really honored to be a part of this meeting, to this webinar. Starting with Niranjan sitting at the top as an organizer, I can say Niranjan is a wonderful person. His honesty, simplicity and dedication to the subject can be summarized in one line, that there was a very important meeting Bharti kept at Kanpur once upon a time, and I was supposed to be the chief guest over there. Unfortunately, because of certain unavoidable circumstances, I could not go and attend it. Will you believe it? Niranjan came to my residence with the memento, with the flower vase and whatnot. I was so overwhelmed. He is such a loving person, such a nice person, that at any length of the time I can talk to him, and I wish him a straight road vertical success up to the highest station of the Foxy. Treasure is just a middle station. Niranjan, can you hear this thing? This treasureship is a middle station. So I'll tell you that you must go to the highest station, the property, the kindness and the work, the academics which you have got. Our co-chief guest and guest need not to tell much about it. We are a part of the family. Usha ji, Meera and Narendra, we think one, We are only simple three persons, but you can say that you tell us one thing to do. If I will say, Ushaji will do, if she will see, I will do. Need not to argue, need not to question. It goes without saying, everybody's word is a religion to each other. It's not a duty, it is a part of religion. So we take it for granted. And I personally feel that our next generation, our students, including Bharti and everybody, they are following the same footsteps. And I am very proud to tell you that we belong to a family in the UP that यहाँ पर एक ही हुक्म चलता है, वो बड़ों का प्यार. And all of our students, they agree to it. आपस में झगड़ा कर ले, बात कर ले, कुछ बात दूसरी है, लेकिन starting from the Naren sitting on the top, ex-president Jaideep, I mean so nice person, कभी भी हम लोगों की बातों को कभी टालते ही नहीं है. तो हम लोग यही सोच समझ के बोलते हैं कि ऐसी बात बोले, ये ना नहीं कर सकते हैं, इन्हें हाँ करना पड़ेगा. तो ये भी हम लोग को सोचना पड़ता है. आज के सब्जेक्ट उषा जी ने बताई दिया, आई नीड नॉट टू टेल, अभी हम लोग सब सुनेंगे बैठ करके. आज के चेयरपर्सन हमारे सब अपने अजीज लोग हैं और प्रेजेंटर्स तो व्हाट नॉट. इट्स अ सब्जेक्ट विच इज अ डायनेमिक सब्जेक्ट, इट्स चेंजिंग डे इन डे आउट. Recurrent pregnancy law is a subject which anybody, right from MBBS up to the DNB, can keep on, you see, just rotating. It is a changing subject. Bharti, you are doing a lot of work in the MTP committee. Very many things must be learned by, they must keep as a notes. Our students, you are very nicely doing it. Your committee is doing very nice. And with these words, my best wishes to Usha ji, Narendra, Niranjan, and organizers, Bharti. It will go a long way for two. I know we extend our heartfelt wishes, good wishes, and love to all of you. Niranjan,
Thank you, madam.
Thank you very much.
Thank you, madam. I bow down to all of you as a teacher, as a doctor, as a Foxian, as an IAG member. I should contribute. That's what I believe.
Yes.
And I should give it back to the society, and that's what I'm trying.
Right.
Doctors, I leave it to Almighty and I leave it to all the seniors. शत शत कोटि प्रणाम आप सभी सीनियर लोगों को. और इसी के साथ हम आगे बढ़ते हैं. I admire the words which you have told that हम लोग सब सीनियर लोग की आदर करते हैं और उनका ही बात सुनते हैं. And this culture of North India has gone all over the rest of India, and that's what we follow. Thank you, madam, for all those beautiful words. Now I would like to call upon Dr. Bharti Maheshwari, madam. She is our
before you start,
yes, sir. And
before she starts,
yes, sir.
Happy
Yes,
Teachers Day.
Shaji, namaste.
Happy Teachers Day to Usha Sharma,
Namaste.
Meera Agnihotri, Bharti, all the professors. तीन professor बैठे हैं. Happy Teachers Day to all of you.
Thank
you, sir.
Thank you, sir.
Thank you so much.
So much.
Yes.
Now I would like to invite Dr. Bharati Maheshwari, the efforts which she has taken, and today we have made history because we always believe in making history, and this program was to happen last month, but it was due to technical reasons. We all got together and it was just an opportunity to meet and to mingle with all of us. We can't meet physically without wasting much time. I want to call upon Dr. Bharti. We have got today Meerut, Agra, Aligarh, Mathura, Noida, Greater Noida, Saharanpur and Haridwar society is with us, and I'm sure many people will join. Dr. Maheshwari, please take over. Thank you so much.
Thank you, Dr. Niranjan. But before starting, I will request Dr. Rukma madam. Yes, please say a few words. He was trying but could not connect. Yes, madam. Professor Rukma.
No, sorry, Bharti, my Wi-Fi was having some problem. Now I'm very well connected. And thank you for this, inviting me in this program as a chairperson. And really, you are a very hard person to work in this field. And since so many years, you are working for the Foxy, for Meerut Society, and we are proud of you, Bharti.
Thank you, madam. Like whenever there is some academic program, I can't forget such experienced and senior teachers. Dr. Bilasha Gupta, madam, if you can hear me, you can say 2 minutes because there is some issues of connectivity. Dr. Bilasha Gupta, I can see you, but madam will, as an expert, she is invited. In the end, she will summarize if she is not able to see. So thank you very much. And Dr. Naren Malhotra sir, I want to say special thing for Naren Malhotra sir that I wanted in this program Meera madam, Naren sir and even Chandravati madam, but because of some reason she couldn't come. She has some other engagement. And I just send a message. I know that all of you are so busy and have so many programs, but only by my message you have just respond and say yes, I will come. Believe me that only presence of your, even only for a few minutes and your 2 lines, they make the program memorable, and all audiences, those who are young generation, residents and all teachers and societies members, we really get energized and inspired by seeing and by hearing few words of you. It's really great pleasure for me that you all are here. So I think that I am just going to deliver this talk, but Dr. Niranjan has deputed me, and I am really grateful to Dr. Niranjan Chavan for trusting me and giving me this responsibility. And I will not take more than 15 to 20 minutes because I know the topic is very vast. But I will mark only, I will take care of time. So share screen. Yes. So chairpersons already we have asked Dr. Priyanka Garg, she is the Secretary of Minute Society, and Dr. Anurita Singh.
Bharti, let me introduce you. Good evening, everybody. On the eve of Teachers' Day, I wish all my teachers a very happy Teachers' Day, and we seek your blessings. Thank you so much. And thank you, Niranjan and Bharti, for giving me this opportunity to be here in this August gathering. I will introduce the speaker for the evening, Dr. Bharti Maheshwari. She is professor and HOD, Muzaffarnagar Medical College. And we all know she is the chairperson of the Foxy MTP committee. She has a fellowship in medical education by MCI. She got elected as the governing council member of ICOG. She is the Joint Secretary of UPCOG and the Vice President of Meerut Obs and Gynae Society. She is the author and editor of many textbooks of Obs and Gynae subject, published many papers and articles in index journals, and delivered the Kamli Rao oration and other talks in national and international conferences. She has organized North Zone and UPCOG conference as organizing secretary. I invite Dr. Bharti to speak upon isoimmunization in pregnancy. Dr. Bharti.
Thank you, Dr. Anurita madam, for introduction. And now I come to my topic, and I will not take more than 15 minutes. So management of RS negative pregnancy, we all know about this issue, but here just to have some update, what recent. We all know that RH isoimmunization an important clinical entity in India and other developing countries, and it is responsible for fetal anemia and hydrops fetalis. And if not treated, it can result in intrauterine fetal device. An important thing is that it is can be prevented with simple measures and treated if recognized in time. That's why we are discussing today, and we all know that RH isoimmunization, also known as RH incompatibility or RH disease, hemolytic disease of newborn. And especially it occurs when RH negative mothers carry the RH positive fetus, and she may be sensitized to RH antigen and develop antibodies. And when these antibodies cross the placenta and causes hemolysis of red blood cells. How these antibodies cross the placenta? Either by mismatched blood transfusion or when RH negative women bearing RH positive fetus with feto-maternal hemorrhage. What is feto-maternal hemorrhage? When during pregnancy leakage of fetal cells in the maternal circulation, then this is called feto-maternal hemorrhage, and it can occur during abortion, APH, stenocephalic version, scordosynthesis, CVS, amniocentesis, or severe preeclampsia, ectopic pregnancy, cesarean sections, manual removal of placenta, and silent feto-maternal hemorrhage. So these are the different causes of feto-maternal hemorrhage. So to know the history of sensitization, we have to ask all these things in the history. So what happens actually that pathophysiology following feto-maternal hemorrhage, there is initial response of the mother that they forms the IgM antibodies for the short period, 6 weeks to 6 months, and followed by production of IgG on subsequent pregnancy, which crosses placenta, and this crossed antibodies, they causes hemolysis in the placenta circulation, and which lead to severe anemia and hypoxia. You can understand by this that this is a negative woman and have a positive husband. They carry the positive fetus, And after some feto-maternal hemorrhage, even a slight feto-maternal hemorrhage, these positive antigens, they travels to the mother circulation, and there is this red, green, this becomes the antibodies. I have showed it. So there is a antibodies against this RS positive fetal antigen, and these antibodies initially they are IgM in large size, but after 6 months around they become the IgG antibodies when they produce. They crosses the placenta and they destruct the fetal cells because these are against the RH positive antigen. And then after that, there is a destruction. There is a destruction of fetal cells by fetal reticuloendothelial system, fetal anemia, which leads to fetal hypoxia and stimulation of erythropoietin. That's why initially it was also called erythropoiesis fetalis. And then extramedullary red cell synthesis, which leads to hepatosplenomegaly, hepatic cell failure, and finally hypoproteinemia, increase intrahepatic pressure, portal hypertension, which all leads to ascites, edema, hypoxia, placental thickness, increased polyhydramnios and pericardial effusion. And most of these things can be diagnosed by the ultrasonography. So, and this is important slide when it is shown that in the first pregnancy, because of this pathophysiology, then normally feto-maternal blood transfer occur during labor. So, first newborn is safe because the antibodies which are destructing to the fetuses they make forms around after 6 months. So mother, which is in the after first delivery, the baby is normally safe, but mother is now sensitized to RH and D antigen. And in the next pregnancy, as mother is already sensitized, repeat encounter with fetal RHD antigen, rapid production of IgG NTD by mother, finally maternal IgG NT cross placenta, and they attach the fetal RBC causing destruction, and the baby can have mild or moderate anemia, jaundice according to the transfusion. So, but here this is important thing that all women doesn't have same response. So why this is so? Because development of RH antibodies depends on the inborn ability to respond to RH antigenic stimulus. Protection if ABO incompatibility, because we all know that when there is a ABO incompatibility, so there is a group O RH negative, and there is anti-A and B antibodies and also antibodies for the B group also. So whenever there is a feto-placental hemorrhage, so these cells they are destructed by or destroyed by the antibodies by A and B. So there is no formation of antibodies and no destruction. So this is again the ABO incompatibility is little protection for the sensitization and immunization. The strength of RH antigen stimulus, it is responsible for development of antibodies. Volume of leaking fetal blood is also important. And immunological non-responders, they are found in 30% of RH negative women, so that even after sensitization and immunization, baby is safe. So this is we almost know this chart that feto-maternal hemorrhage, the chances of feto-maternal hemorrhage were evident that 6 to 7% in the first trimester, 13 to 14% in the second trimester, around 29 to 30% in the third trimester, and 40 to 45% during labor. So as the gestational age increases, the chances of feto-maternal hemorrhage increases, and the 0.1 ml blood minimum is required to do the 1% sensitization. And more than 5 ml blood is required, and if it is done more than 5 ml feto-maternal hemorrhage, then there is a 65% chances of sensitization. So amount of feto-maternal hemorrhage is also responsible for the severity of the disease. Complications, we all know that hydrocephalus, stillbirth, ictus gravid neonatal, neonatal jaundice, neonatal anemia of newborn. This is a picture that how we get. So finally, what is the aim of antenatal management? First and foremost is to predict which pregnancy is at risk. So even in the prenatal counseling, in the first antenatal visits, and every time we have to ask that which pregnancy is at risk, then to predict whether or not the fetus is severely affected. Then if it is so, then correct the anemia and reverse the hydrop by intrauterine transfusion, and to deliver the baby at appropriate time, comparing or weighing the risk of prematurity as well as intrauterine transfusion. So management, the first issue is that how we have to identify that which women are non-immunized and which is immunized. If woman is non-immunized, the aim is prevention of alloimmunization. And if it is already immunized, then early detection and adequate treatment of early anemia. So how we know the immunity status of this? By the simple indirect home test. And this indirect home test, and we should also know what is the direct home test. Actually, in direct home test, we do indirectly the fetal blood cells after fetal blood after delivery in the fetal cord blood. Indirect home test, it is done with the mother cells, and here you can see that the mother's blood patient sample, it is mixed with the Rh positive antigens, and then when these antigens, as mother is if they are having the antibodies already immunized, then they will adhere, and then we will mix it with the anti-immunoglobulins, that is the home serum. Then if there is an agglutination, means indirect home test is positive, means woman is immunized. If it is so, then we have to do the anti-D titers, and it should be done if it is below the critical layer every 2 to 4 weeks. And normally it is said that if titer is less than 1/16, then fetus is not at risk. And if titer is more than 1/16, then severity of condition should be evaluated. Genotype of husband is to be determined. Why it is required? Because if husband is homozygous, then chances that if husband is homozygous, means it's having the both be then positive, then chances that all fetuses, they will be positive. So if husband is homozygous, we are not supposed to see the baby fetal blood group, because it is supposed to be positive, Rh positive. We have to manage accordingly. But if it is heterozygous, then it should be suppose we should see the fetus blood group, and it may be in 50% cases negative. So in those cases, we can avoid these exercises. So basically, we can see that when we do the ICT titer, if we think that it is a ICT is a positive, then we have to see ICT titer. If it is less than 1/16 solution, we have to continue the titer every 2 weeks and deliver at normal time, but of course not allowed to be the post-static, and no NTD prophylaxis actually needed at this time if it is unimmunized. If ICT titer is negative, then repeat titer every 4 weeks. Give NTD at 28. In some cases, they do from the first visit IT titer and then repeat every 24 weeks till 28 weeks. In our cases, we can do if it is negative at the first, and then we can give anti-D at 28 weeks, 300 microgram intramuscular, and repeat anti-D 300 microgram within 72 hours of birth if baby is Rh positive. And if it is more than 1/16, then we have to follow the fetus by the middle cerebral artery, peak systolic velocity, and seeing the features of hydrox and manage accordingly. How? I tell you that by if it is Rh positive, then we have to determine the gestational age as well as determine the paternal serology and phenotype. And if this is a positive, then we have to obtain the serial antibody titers. If critical titer is reached and there is a heterozygous paternal phenotype, then nowadays you have to know if it is a heterozygous, you have to know the fetal blood group. It can be known either by, nowadays we have a system where the maternal blood, this is a recent advancement where by the maternal blood you can, by the DNA detection, you can check the fetal blood group. This is a costly investigation, and here you avoid the amniocentesis. Otherwise, by amniocentesis, you can get the fetal genotype. If it is positive, then of course you have to, if it is negative, no further studies are required. If it is positive, then now amniocentesis is replaced by the serial middle cerebral artery Doppler peak systolic velocity. I will know how it has to be done. So if it is more than 1.5 MOM, then it is a critical layer, and you have to do the fetal blood sampling for fetal hematocrit. And if it is less than 30%, then you have to see the gestational age. If it is more than 35, you deliver. If it is more than 35, you have to deliver the baby, and if it is less than 35, then you have to treat by the intrauterine transfusion. And if fetal hematocrit is more than 30%, you have to just follow the patient by simple MCV. Now, how we assess the fetal assessment of the fetal hemolysis. You may know that in initial ways we have only options of amniocentesis and photosynthesis, but now we can have a very good option of ultrasonography. By ultrasonography, not only you can see other features like placenta size, thickness, hepatic size, fetal height drop, pleural effusion, ascites, pericardial effusion, but Doppler assessment of peak velocity, it is very helpful to know the critical condition of fetus. So actually, middle cerebral artery Doppler velocimetry, it is accurate and non-invasive screening tool for detecting moderate to severe fetal anemia. The sensitivity is 100% and 12% false positive, and has resulted in up to 80% reduction in invasive testing like the amniocentesis and chordosynthesis. You must be remembered your old time Lilly charts and all, but nowadays this middle cerebral artery Doppler velocimetry, it is very useful, and it is helpful in 18 to 35 weeks of gestation, and found to be similar or better than amniotic fluid analysis for the prediction of anemia. This is a normal middle cerebral artery Doppler, and this is, you can say that in RH isomerization, that peak systolic velocity, this is increased so much. And if it is more than 1.5 MOM, then it is moderate to severe anemia and you have to manage the patient. So if it is PSV, it is more than 1.5, you do fetal blood sampling and consider for the intrauterine transfusion. And if there is no facility for fetal blood sampling like chordosynthesis, then even you can do the amniocentesis to know the fetal blood group. So this is amniocentesis. We all know that it is an invasive procedure, but can be done, and it is a coronary villus sampling. Of course, it is done in the initial time in the fetus 8 to 10 weeks. At that time, we now don't prefer it, because if it is RS positive fetus, the chances of alloimmunization is also there. And nowadays, we are not using these things. Chordosynthesis, it is a complicated procedure but it is useful for the fetal RH phenotype as well as for checking the hematocrit. Gold standard for detection of fetal anemia. Greater morbidity and mortality, and 2.7% of total risk of the fetal blood clot. So here by the umbilical vein, you take the sample, ultrasound guided, and manage the thing. And if it is required, it is hematocrit is less than 30%, then you have to do intrauterine blood transfusion. And it is recommended that in between 18 to 13 weeks of gestational age may be given intraperitoneal or intravascular, but nowadays prefer the intravascular, sometimes combined. But ORHD negative fast cell with hematocrit of 80% is used. An amount to be transfused, we can calculate it by the intraperitoneal and intravascular methods. And intravascular, the goal is to have a post-transfusion hematocrit 40 to 45%, but at least more than 25%. An estimate requirement based on effective fetal weight and pre-transfusion hematocrit. Repeat in a 1 week and throughout at least about every 3 BT. And you can see that this is a direct fetal intravascular transfusion in the fetal umbilical vessel. And this is the management and important precautions during delivery. You have to ensure the consultation with neonatologists. Don't give oxytocin at delivery of anti-shoulder. These all precautions are for prevention of feto-maternal hemorrhage. If manual removal of placenta is required, do so gently. Normally during cesarean, please don't keep your hand inside and don't remove the placenta. If blood transfusion is indicated, use RH negative blood only. Early clamping of umbilical cord is indicated. Leave a long length of cord about 15 to 20 centimeters. At birth, this is important because things you have to do that maternal blood, you can check the ICTs as well as sometimes you assess the feto-maternal hemorrhage also. And the cord blood samples we all take, and we do the direct home test to detect the antibodies as well as infant blood grouping, RH typing, infant bilirubin level, and infant hemoglobin and hematocrit level. And this is sometimes we all should know that we have an option to detect how much feto-maternal hemorrhage is occurred, and how we can detect. First, we have to see whether it is done or not by rosette fetal RBC screen. This is a rosette test. If it is positive, means if it is positive means clamping is there. So if it is positive, then you check that how much amount of feto-maternal hemorrhage is done. And Clay-Hawker-Betke test, by this you can check how much amount is done, and it is by the simple acid dilution test. You can separate the fetal blood cells and the adult blood cells, and by some formulas you can calculate that how much fetal blood is inside the maternal blood. So and why this estimation is required? Sometimes it is required because normally the normal amount of fetal blood which we expect that enters the maternal circulation is less than 0.5 ml. So dose of immunoglobulin which we give 300 micrograms, it is sufficient because it neutralizes around 30 ml whole fetal blood and 50 ml RS positive fetal blood. So management is guided by estimated volume of FMH determined by 4-step lab test. Dose of RH immunoglobulin given after sensitization in at least 20 microgram per ml of fetal RBC means sometimes if we suspect that there is a higher feto-maternal hemorrhage, at that time extra dose may be required for the fetal immunoglobulin. So finally, the RH isoimmunization prevention is screening of all pregnant mother to do RHD against RHD antigen and antibody screening for RHD negative mother. And this is the important thing, that rule of thumb that should be to administer anti-D immunoglobulin when in doubt rather than to withhold it. So finally, non-invasive fetal RST genotype-free DNA. This is a recent advancement. I have already told you that this is available. That you are not supposed to do cardosensitive and amniocentesis for RH genotyping. You can detect it from the simple mother blood, but I got it, and it is in Delhi around 15 to 20,000. And point of care test. This is also for the rapid test for determining the RH status. Recent advances, and lower 50 microgram dose preparation is now for use following first trimester abortion. And concept of partial D and weak D antigens, this is also in the recent. So take home points that every woman of childbearing age should have her ABO and RH type done at first contact. And in fact, awareness about this should be there so that every woman can get it. Obtain the RBOH type of husband of woman found to be RH negative. Ensure ICT is done at 20 weeks or then till 28 weeks of pregnancy, and then appropriate prophylaxis. Single postpartum dose may be inadequate in case of severe feto-maternal hemorrhage in some cases, where you are suspecting that large feto-maternal hemorrhage. Either you give additional dose or you can calculate the feto-maternal hemorrhage and accordingly. So prognosis of alloimmunization of mother and baby depends on genotype of father, genotype of fetus, maternal antibodies level, history of previous affection of baby due to hemolytic disease, availability of sophisticated diagnostic and therapeutic facilities of affected baby. And nowadays we have lots of fetal medicine departments and facilities. However, with use of intensive management protocols such as repeated fetal MCA Doppler study, amniocentesis, cardiosynthesis, intrauterine fetal transmission, then neonatal survival is 100% if judicial decision is taken in the right time. So this is the all indication of anti-D immunoprophylaxis. We all must not forget to give it is immunoglobulin prophylaxis when we are having these cases: miscarriage, ectopic, MTP, samplings, amniocentesis, fetal blood sampling, APH, abortions routinely at 28 weeks after delivery, molar pregnancy after abdominal trauma. So finally, management of a RH negative woman should be in a tertiary center where facilities for intrauterine transfusion and exchange transfusion is there. So it is a RH isommunisation. It is a potentially preventable condition that occasionally is associated with significant perinatal morbidity or mortality. Disease severity may be assessed during the modalities described above, and frequently invasive techniques are required to determine the risk of severe fetus. Studies appear to offer accurate, non-invasive means of evaluating fetal risk, which may allow for a decrease in invasive diagnostic measures. So, RH isommunisation managed by an experienced team can anticipate a favorable pregnancy outcome. Thank you very much.
Thank you. Thank you, Dr. Bharti Maheshwari ma'am, for such a crisp and nice presentation. सभी टीचर्स, मेरे टीचर्स यहाँ पर बैठते हैं टीचर्स डे की उप संध्या पर. डॉक्टर उषा शर्मा मैम, डॉक्टर रुकमा इदनानी मैडम, ओवर प्रोफेसर भारती माहेश्वरी also, she has been my teacher cum guide, and teachers of teachers, Professor Meera Agnihotri ma'am, Dr. Niranjan Chauhan. Hello, sir. I had presented once in UP chapter, and sir came to me and said, Dr. Priyanka, what a crisp presentation. A man who can move so many steps to congratulate anybody. Thank you for being with us. And RH immunization is one of the important topics which is preventable, and as ma'am has rightly summarized, that the key to success is giving proper NTD at proper time rather than withholding it, and proper screening with indirect Coombs test. I think each and every point was covered very well in the presentation. Thank you for making me a chairperson.
Thank you.
Thank you, madam. Now I have one or two questions, if you permit, and then we will move on to the panel. Dr. Bharti Maheshwari, you have finished on time, and I appreciate that you have not taken more than 22 minutes. It is amazing as a teacher, and the way you have presented was very nice. Many people have appreciated. There are many comments which are coming here appreciating your lecture and the amount of energy you have to get this whole team of 8 societies coming together. The question is, madam, what is the dose to be given in the postnatal period, postpartum, if it is an RH negative mother, and how much is the dose, and how and when do we give? Do we give it before 72 hours or after 72 hours?
Dr. Niranjan, and with every audiences, I want to say that after delivery, within 72 hours, you have to give 300 microgram NTD. And I have as told you that we have fixed this 300 because of in majority we expect that the fetal-maternal hemorrhage is not more than 0.5 ml. But in cases, if it is exceptional cases that we think and we are at higher center, we can assess them. But otherwise, it is 300 microgram.
So just to add on, if it is not given within 72 hours, an extended dose, it can be given till 1 month. But that doesn't go that we wait for 1 month to give, but it is always better to give it rather than withholding it. We need to remember this point.
Definitely, because antibodies take time to form, so it can be helpful even if it is given little late. But preferably should be given in 72 hours.
Thank you, Dr. Bharti and Dr. Priyanka for your comments. Dr. Nidhi Gupta writes from Agra. Excellent presentation, and there are many comments which are coming. One more question is from Dr. Gurdevi Srivastava, Agra. If antenatal case is ICT positive at 20 weeks, whether to give anti-D injection immediately? What is your answer, madam?
If it is already, she is already immunized, then you can do the antibody titer. But in some literatures, in some studies, they say that they give. Because advantage of giving the immunoglobulin is just that those who are not having the antibodies to produce antibodies. But if it is already done, but because you don't know how much, so you can give, there is no harm. Some other expert want to say something?
There's one thing I also want to add. See, it is not just D antigen. Now we are also testing for C, D, E, K antigens as well. So there is a clinch in between for giving anti-D. This anti-D provides anti-D immunoglobulins provide protection against other antigens as well. So as Bharti has rightly told, that there are certain studies which say that there is no harm in giving even if the ICT is positive in very low titers.
Thank you, Dr. Priyanka. Now we have got one more question from Dr. Nirpan Sharma from Meerut. Does indirect Coombs test help in assessing the danger to fetus? How to proceed if ICT is positive?
I have told all my lecture on this, but I again just in short repeat, if ICT is positive, definitely ICT titer is just dictating that how much fetus is affected. If it is more than 164 or it is rising 164 to 1 is to 254, then rise in the 7 weeks, definitely it means fetus is severely affected. So you have to do the, if it is in the critical zone, you have to check the fetus hematocrit and you have to do intrauterine transfusion or whatever it is required, definitely. ICT titer is related to the severity of fetus.
Thank you. And then we have the last question here coming. Dr. Bebo, love this webinars for non-sensitized RHD negative pregnant women. Is routine prophylactic antenatal anti-D administration compared with no anti-D effective for preventing rhesus isoimmunization and improving outcomes?
I don't know, she is telling or she is asking, but I think she is giving some reference. But here, if it is not sensitized, non-immunized, definitely we have to give 28 weeks immunoprophylaxis.
Sir, it is now in studies, they also give it 28 weeks and 36 weeks. Yes. We are not promoting anti-D injections here, but this is the key to success. Please give it whenever in doubt. Maybe like in patients who keep on bleeding off and on, then you keep on repeating the injections because this is something which is a disease which is preventable and it is always better to prevent. Yeah.
Dr. Reena Shrestha from Kathmandu. We have got viewers from Nepal.
Oh, great.
It's amazing.
National webinar.
So she's asking, thank you, wonderful presentation and webinars been done by you, Niranjan. How is it important to do ICT test in primary gravidas before 20 weeks of gestation?
ICT at 20 weeks is okay because if it is primary gravida, you can do it any gestational age. But if you get the 20 weeks, then you will achieve your objective. I think it is because before that, fetal-maternal hemorrhage and other thing is not possible. So, and how you know that it is non-sensitized? Only by doing the ICT. So if once you will do, then you will get it is non-sensitized. Then you have to do at 20 age.
Thank you. Last question. This is from Vizag. We have got members coming from South India. So this is what is bridging Bharat. We are
Yes.
bridging South India to North India and West to East. And we have gone international. It's amazing. This is Dr. G. Indira. If patient undergoes tubectomy, do we still give anti-D?
Patients undergo tubectomy, so there is because we have done that, we can give no harm if it is RH negative. Ideally, it should given. It should be given if it is RH negative. Or
If she decides for a
if it is-
recanalization
it is
later
not
on.
in literature, but you can give if you think that otherwise not.
Thank you, Dr. Bharti. It was a wonderful presentation, and we will come back to you soon. And all the best for your future endeavors. Please be there. And thank you, all the guests of honor and chairperson. I would like to specially thank Dr. Anurita Singh. Dr. Anurita Singh and Dr. Priyanka have done a wonderful job, and you are the torch bearers.
Dr. Niranjan,
Yes.
our expert, Dr. Rukma madam is here. Dr. Vilas and Dr. Kirti, I am not able to see. Rukma,
Yes,
madam,
madam.
you want to say as expert?
Yes, they can have just one-liners and then we
Yes.
move on to the panel, madam. Thank you. Yes, please go ahead.
Okay.
Please.
Very lot of change has been made in the management of the RH isommunization. In our time, there was a different. But really, it's very good that we can maintain the morbidity and mortality. So we can prevent it.
Thank you, madam. Thank you. So now,
Yes.
Dr. Niranjan, you are moved to next session. That is the panel on the RPL.
Thank you. Thank you so much. Now I would like to thank all of you to be here, and please be here. Please be there to guide us. Rukma Idnani madam and all the experts, you are still going to be there. I request you to raise your hands in case you want to say any comment or any word in between. These cases will be discussed by the panelists. So we would love all of you to be there and guide us at the end of all these 6 questions. Once the panel discussion is done, if any points are being left out, that's what the special experts and the chairpersons are going to be here to guide us. With this, I would like to open up my presentation, and we will go ahead with the screen sharing, and I hope it works. Yes. So we are today in North India and wonderful state of North India. I hope the weather is lovely, and without wasting any much time, I would request now, before I share my slide screen, sharing the screen, I request Meenal to please open up the panelist biodatas. Thank you so much. Well, we have luminaries from all the societies who have come together, and we are going to have a wonderful time with each one of them, sharing their experiences and sharing their talent and giving their opinions. So I request now Minal to please show me the panelist, 6 panelist names. Yeah, please go down. Yes, I think that's fine. Is that? Yes. Well, welcome Dr. Ruchi Srivastav. She's the Secretary of Greater Noida Obstetric and Gynec Society and Professor of Department of Obstetric and Gynec at Sharda Hospital. Thank you. Next, Dr. Kanika Singh. You're from Meerut and a member of AIA, SRM, IFS, Foxy IMA, Fellowship Cosmetic Plastic Gynecology in USA, and PGD Ultrasounds Delhi, laser training from Europe, LAHA Academy. Welcome, Dr. Kanika. I welcome Dr. Nutan Upadhyay, President of Saharanpur Obstetrics and Gynecological Society. She's a Director of Santosh Hospital and Research Center, Director of SOM Healthcare Center and Herbal Specialties. Welcome, ma'am. Dr. Anshu Raina. She is a Senior Consultant in Kailash Hospital, Greater Noida, Secretary of the Noida Obstetric and Gynec Society. She was also the Joint Secretary of North Zone UA Foxy 2019. Welcome, Dr. Anshu. I also welcome Dr. Samta Gupta, currently working as a Senior Consultant, Obstetric Gynec School of Medical Science and Research, Sharda Hospital, Greater Noida, Treasurer of the Greater Noida Obstetric Gynec Society. Thank you for joining with us. Thank you. And our last panelist is Dr. Sonal Agarwal. She's an MBBS MD, consultant and laparoscopic surgeon, GR Hospital, OC Kalan, Mathura. So I welcome all of you.
Thank you, sir.
And thank you so much for joining today's panel without wasting anyone's time. We have to respect the time of the audience who have been with us and all the members who have been part of this webinar. A wonderful presentation, Dr. Professor Bharti, madam. We will come back to you soon. Thank you. So we go ahead. Can you see the slides? But I can't.
Slideshow.
No, I can't share. 1 minute. I will have to. Can you see this now?
Yes, yes.
Yeah, thank you. Please acknowledge, please acknowledge. Thank you. So I request only the cases panelists to be taking and unmuting their mics. The rest of them, please mute your mic. And we are going wonderful. We are not on time. So when we have patients coming with RPL and you're an endoscopist or you're a general obstetrician, what are the common questions which are asked by the RPL patient? What do they want? And this is what is the state of affair. In even Corona times, we have to take their video or telecon. And why did it happen? Will it happen again? How it can have been avoided? Could have been avoided? So all these things, questions are there. And that is what we are dealing today. It's an RPL, that is recurrent pregnancy loss. It's the most difficult step which a woman undergoes, and obstetrician treating them. It is estimated 50% are lost before the first missed menstrual period, and the actual rate of pregnancy loss after implantation is 31%. Clinically recognized loss occurs in 15% before 20 weeks of gestation, and it is a fact that most common complication of pregnancy which you can see. And you know what the worst part, or what I can say, we are the 30% alive here, sitting here. 70% of them even fail to achieve viability. So we have a normal population and chromosomal anomalies contribute 50%, and this is the breakup you can see, and we will be discussing this case. So what is the definition of RPL? To begin with, we all know any 3 or more losses which occur before 20 weeks period of gestation from the LMP is RPL, and it can be primary or secondary. The incidence is 1 is 300. So primary is basically referred to couples that have never had a live birth, while those secondary RPL refers to those who had repetitive losses following a successful pregnancy. And if you see this slide, it's so wonderfully, displayed here. It goes through all the causes: genetic cause, fetal anomalies, uterine anomalies, immunological causes. There is hereditary thrombophilia, coagulation defects, trauma, endocrine, alloimmune, infections. So we will travel through all this one by one and hope we finish all these cases on time, and we will have expert opinion from the most of our people and even audience interaction. TOG webinar always does audience interactions, and we get many questions as the amount of users which are logged are much more. This is also the breakup, what you can see here on the right hand side, and the genetic, anatomic, endocrine, infectious, immunological and other factors contributing. So now I call upon Dr. Ruchi Srivastava to present her case, and I will guide you through this slides. And I will not even interrupt you in between. You can please go ahead and present your case. Welcome, Dr. Ruchi.
Okay. Good evening, everyone. And my special thanks to Niranjan sir and Bharti ma'am for inviting me as the panelist for this session. My case is, she is a 24 years old Mrs. MSJ, married since 5 years. Her obstetric history is very important, and we always have to take a detailed obstetric history in these kind of patients. The first pregnancy she had was a vesicular mole, and she underwent dilatation and evacuation. The second, sir, can I have the previous slide? The case presentation.
Sorry. Yes, madam.
The second pregnancy was again a missed abortion at 7 weeks. Third pregnancy was again a missed abortion at 6 weeks. And finally, when she had the fourth pregnancy, it was a blighted ovum at 6 weeks, and she terminated it with the medical management. Her menstrual history was regular. That rules out the luteal phase defects and other problems, the ovarian problems. There was nothing significant about the medical history. That means it rules out all the tuberculosis, thyroid problem, and diabetes, hypertension. Family history also was not significant. That means there was no history of any abortion or recurrent abortion in the families. I'll tell you why it is important to ask in the family history about these things. Clinical findings were normal. All her hormonal profile were done, and that too was normal. EPLA was negative, which we always do. And this shows that the patient had nothing specific which we were mentioning about the causes of or the etiologies of the recurrent pregnancy loss. The last thing which we did was a karyotyping in this patient. The husband was a normal, healthy male, and the karyotyping was normal, 46XY. Whereas when the karyotyping of the wife was done, it showed 46XX, and 2 chromosomes were involved in this, the chromosome 11 and 22. GTG banding showed that the reciprocal balanced translocation was involving these 2 chromosomes, 11 and 22. There was a breakage and reunion of these bands at 11q24 and 22q13. That means the wife is the carrier for this translocation. FISH was done. It showed the balanced translocation between 11 and 22 involving the breakpoints at the similar points respectively. Can I have the next slide, sir? So the question given by sir is that, is the cytogenetic studies of the conceptors, should we always do them? The answer is that cytogenetic studies are done to rule out the genetic etiology of miscarriages for 2 reasons, whether it is de novo or it is inherited one. So we have a list of the inherited one, the aberrations abortus, the most common being the trisomy that consists of 66.7%, though monosomies are very less or very rare, except for 45XO, that is the Turner syndrome, it is 13.9%. Triploidy again is 13.9%. We have tetraploidies also, which is of a lesser percentage, 3 to 4%. Structure abnormalities, though that includes the unbalanced translocation, is 5.5%. To add on to this list, when I was reading few days back, I just came across one newer thing, that is single gene disorder, and that is a very recent one. That's the reason we do not have the percentage till not known till now. But the development has been taken up for this, and the evidences have come up, and that shows that 20 different genes which can cause RPL, and they are very lethal if they are present in the abortus. We have other, sir, can I have the next slide? Yes, definitely the maternal age has a relation with the aneuploidy. As the maternal age increases, the aneuploidy risk in the abortus or the aneuploidy increases. If we talk about 22 to 24 years of a female, if we check about if we do the karyotyping in that, the risk of abortion with these kinds of problems is only 11%. Whereas when we do it at 40 to 45 years, the risk increases tremendously up to 50%. It is very high at this age group. Next slide, please, sir. Yes. The authors or the scientists have worked upon the aneuploidy, and it has been seen that repeat aneuploidy is there around 15.1% in the subsequent pregnancy. To be on the positive side, if we look onto it, that the aneuploidy is not going to be there in around 85% of cases. So Now, we have to understand as the gynecologist, as the obstetrician, that at what point of time we have to refer the patient to the geneticist. So it is not always that the patient is having this kind of a problem or a genetic disorder and straight away we refer the patient to the geneticist. We have to work on her, we have to make her understand, we have to make ourselves understand that what else or what best thing or what possible thing we can offer to this patient. Next slide, sir. There are subsequent pregnancies, and what is important about it, the patient is very much worried. She says if she has aneuploidic abortion, then is she going to have the live birth later on? Definitely the live birth after aneuploidic miscarriage is not less or is not less than any euploidic abortion. So she has a better chance to have a live birth later on. The percentage of live birth is still very, very good in aneuploidic abortions. If it has occurred in this pregnancy, later on she can have a live birth. In all couples with a history of recurrent miscarriage, cytogenetic analysis of the products of conception should be performed if the next pregnancy fails. So in my case, the patient when presented, she already had 3 early abortions, and when we talk about 3 early abortion, that means the most common cause of the first trimester early abortion is the chromosomal abnormalities. The next, she also had a vesicular mole, which was the first pregnancy, and mutations in the multiple genes, the changes in the mutations can lead to vesicular mole. So my patient is definitely going towards the genetic factor. And finally, we did the karyotyping in this patient. So she, the lady came out to be the balanced, having the balanced translocation. When we talk about the cytogenetic analysis, we have evolved gradually with that. We were doing the karyotyping in the conceptors earlier. So the karyotyping had certain problems because it could only give the results up to 50% of the cases. And in 50% of the cases, there was a lot of dilemma that what to do in these cases because it could not pick all the chromosomal anomalies due to the low resolution. Then we evolved to FISH, that is the fluorescence in situ hybridization. It also had its own limitations. Then finally came, which is the recent one, is the microarray. To be more specific, if I say it is SNP, SNP, single nucleotide polymorphism microarray, this microarray has to be tested and the conceptors has to be tested with the microarray. Before going further, I would like to tell the advantage, because when we are taking the conceptors and we are sending it for testing for the cytogenetic studies, it has to be microarray in these days, because the pickup of the paternal origin of aneuploidy is good with this. The resolution is very high. The failure rate with microarray is very less. It's less than 5%, whereas with that of karyotyping is around 40%, and with FISH is 30%. They do it with the biometric evaluation, so the error has been reduced tremendously, and we can get the report with microarray in 7 to 10 days, whereas in FISH or in this karyotype, we get it in 21 days. We have to find out the structural genetic factors also in the patients, because that is the reason we are doing the parental karyotyping. Why not microarray in the parent? Because one important thing about the karyotype, only one thing important is this, that it can pick up the balanced translocation in the parents. Whereas the microarray, this is the only problem where microarray cannot pick up the balanced translocation. So we are not concerned about the balanced translocation in the fetus, because it is not going to cause any anomalous changes, because the balanced translocation carriers are normal. So we do the karyotyping in the parents. And in the previous slides, we had seen that the female had the balanced translocation. What is translocation? Actually, it is a translocation is transferring. It is a transfer of a genetic material from one chromosome to another chromosome. There are 2 types of translocation, the reciprocal and the Robertsonian. We need to understand the difference between these two. Suppose the two chromosomes, that is the 13 chromosome and the 14 chromosome. If the genetic material or a segment of a 13 chromosome goes and get attached to the 14 chromosome, and from that part, that segment of that 14 chromosome comes and get attached to the 13 chromosome, that is the transfer of the genetic material from one chromosome to another, is the reciprocal translocation. Whereas in Robertsonian translocation, Robertsonian occurs in acrocentric chromosomes. There are 5 chromosomes, 13, 14, 15, 21, and 22, in which the Robertsonian translocations takes place. This occurs when 2 chromosomes fuse together. Like, for example, the 14th and 21 chromosome, it fuses together, creating one chromosome that contains most of the original 2. So the chromosome, actually there are 46 chromosomes in one normal healthy person. In Robertsonian translocation, because of the fusion of 2 chromosomes, 45 chromosomes with one variant is there. For example, if 13 and 14 chromosomes in the Robertsonian translocation, they get attached, and there is a trisomy 13, we call it as Patau syndrome. And if it is a trisomy 14, then then this trisomy is actually very lethal, and these patients, they miscarry. If it is trisomy 21, then that is very commonly we see is the Down syndrome. Sir, can I have the next slide, please? So I was talking about that if it's trisomy 21, then it results in Down syndrome. So this is what happens in the Robertsonian translocation. Next slide, sir. Non-disjunction. So the parental diploid cell, they divide into and they form 4 haploid cells. Whenever the separation is not possible between these chromosomes and the chromatids, that leads to non-disjunction during the meiosis. This has to happen. If it is not occurring, we call it as non-disjunction. There are other, the non-disjunction, most commonly the chromosome which is involved is chromosome 16. Can I have the next slide, sir? So this is the equatorial plate at the end, the tips, and they get separated. The chromatids get separated, but in the second picture, if you can see, the chromosomes are not separated, and the trisomy is formed. The incidence of trisomies increases with age, and trisomy 16, which accounts for 30% of all trisomies, is the most common. Next slide, sir. We have other disorders as well, like deletion, duplication, insertions, ring chromosomes. Deletion, I talk it about, like, deletion is deleted. When we delete something, that is a fragment of a chromosome is missing. They are usually lethal when they are homozygous, and they cause abnormalities when they are heterozygous. So Cry-Du-Chet syndrome is one of its type, and it is due to the deletion of portion of chromosome 5. And Cry-Du-Chet individuals are mentally retarded. Next slide, sir. In a balanced translocation, there is 5 to 10% chance of pregnancy with unbalanced translocation. Important is to evaluate. How do we evaluate, and what can be offered to a patient? That is more important. When this patient comes with the balanced translocation, and we know this particular patient or one of the partner is having a balanced translocation, and the subsequent pregnancy, if she's going to have, can have unbalanced translocation, which can be harmful. But not always it is going to be like that. Some balanced translocation can be a normal. If the baby is going to have the balanced translocation from any of the parents, it can be a healthy, normal baby. So what we have to offer, we have to suggest about the expectant management, not directly send them to the geneticist. We ourselves has a role over here. We can suggest them the expectant management, like conceive, and then going for prenatal diagnosis. Prenatal diagnosis includes the CVS, chorionic villus sampling, and amniocentesis. I would not prefer CVS because most of the chromosomal abnormal fetuses, they miscarry in the early pregnancy. So CVS has and increases the incidence of miscarriage also. So amniocentesis is better because whatever the fetus is being carried, there's possibility they can be normal also. The outcome, the successful outcome with the expected management is said to be more than 60 to 70%. So we can give this, we can offer the patient the expectant management. The second is PGTA, that is the pre-implantational genetic testing for aneuploidy. In those cases, that is also has its own pros and cons. So we are not going, or we have to just explain it to the patient. And if we relate both the things, the expectant and PGTA, I would prefer the expectant management at least. The last, because in my patient, she was a carrier, we can offer her for the donor ova. With this, she can have a normal pregnancy later on. And all couples with a history of recurrent miscarriage should have peripheral blood karyotyping performed. That is important. The finding of an abnormal parental karyotype should prompt referral to a clinical geneticist. Then the geneticist has to tackle with these kind of patients if there is absolutely abnormal karyotype. If it's a balanced translocation, definitely we have certain rules and we can follow these patients.
Thank you so much. Professor Ruchi, you have explained very nice. The first case is the stumbling block. And when we start with the journey, always these are the congenital anomalies. And as the further journey goes, it becomes easier and easier. So that stumbling block of genetic anomalies and problems of genetic counseling and the way you have explained about deletions, disjunctions, translocation, meiosis, mitosis, beautifully explained. We will come back to you. Thank you so much. For any questions later. Now I request Dr. Kanika Singh to please unmute her mic and come and present the next case. Thank you so much.
Good evening everyone here, and a very happy Teachers Day to all the teachers present here. And I would like to thank Dr. Niranjan sir to giving me opportunity to be part of this webinar. So I'm proceeding to my case. She's 28 years old, Mrs. XYZ, married since 6 years. She's fourth Dravida Para 1, and her obstetric history, first one was preterm stillbirth at 7-month amenorrhea when she had abruption. The second was missed abortion at 6 weeks. Third was missed abortion at 8 weeks. And fourth was spontaneous abortion at 8 weeks. Coming to her menstrual history, cycles were regular, 4 to 5 days, and after every 28 days, there is no history of dysmenorrhea. And there is a history of childhood asthma in the patient, and history of diabetes mellitus and hypertension in the family. May I have next slide, sir? Yeah. All her routine investigations were within normal limit. On TORCH, her toxoplasma IgG was positive, IgM was negative. Rubella IgG was low positive, IgM was negative. CMV IgG moderately positive, IgM negative. And herpes IgG mild positive, IgM negative.
What does it suggest?
Sir, TORCH is actually IgG titers basically reflects the old infection. IgM titers, if they are positive, that means patient is positive in the recent time. That is suggestive of acute infection. So any of like IgM is not positive, that thing is ruled out here. Coming to like other investigations, her autoimmune profile was done. BT and CT were normal. Platelet was also normal. PT was slightly increased in the patient, and her ACL IgG was highly positive, and IgM was also highly positive. Lupus anticoagulant was highly positive, and her double-stranded DNA was also positive. So which suggests of going in favor of APLA. And yeah, may I have next slide, please? Yeah.
What are the other infections you have to keep in mind? Of course, if this goes to in favor of APLA, but you can just continue.
Yes. Though infections can never be the cause of recurrent abortions, but yes, we do have to rule out, and because studies have never proven that every time when we check for infections in recurrent abortions, we find the same infective organism in infection, and even when antibiotics were given, it's not key, they were found to be like key in next pregnancy, the same organism is found. So infections, though they cannot be the cause of recurrent abortion, but yes, they are found. So kinds of infection like toxoplasmosis, then like other infections, parvovirus, B19, HIV, syphilis, hepatitis, and rubella, cytomegalovirus, herpes simplex infection. And though they are not found in very early, they are usually found in late second trimester and third trimesters. And they become more responsible for preterm rather than early abortions. Distinctive features which were found in such infective patients, such patients who were carrying these infections, were like intracranial calcifications. They were most commonly found in toxoplasmosis, cytomegalovirus, then cataracts, which were more characteristic of rubella, HSV, that's herpes simplex virus, then chorioretinitis, found more commonly in toxoplasmosis, CMV, bone lesions, which are more common in syphilis, rubella, and congenital heart diseases, which are more common in rubella. Microcephaly, hydrocephalus, vesicles, which are more suggestive of herpes simplex virus, varicose, and syphilis, which are more visible on even ultrasound also. So coming to infections and recurrent pregnancy loss, as I told you few infections earlier, in addition, tuberculosis, listeriosis, bacterial vaginosis, TOG, which I have already told, then chlamydia, syphilis, mycoplasmas. As I told, they are not found in very early abortions. They usually lead to as bacterial vaginosis, that is more of causing preterm delivery rather than early abortions. But it's always better to treat these infections whenever we are evaluating and dealing with the patients of recurrent abortion. Yes, coming to genital tuberculosis, in latent GTB, the basis which we found for responsible for the loss of pregnancy is increased cytokines, which alters the ratio of T helper 1 cells and T helper 2 cells, which further causes the surrounding milieu to be abortogenic. Then the another basis which was found in genital tuberculosis was leading to implantation failure, which was due to fibrosis and inflammation, as I told you, because it alters the milieu, causing more of T helper cells 1 type, which are actually pro-inflammatory. So the question here is, does APLA cause early pregnancy loss? Yes, it do. And there are various mechanisms by which APLA causes pregnancy loss are like inhibition of cytoblasts, which is by either invasion or defect in differentiation, then by thrombosis, like platelets, fibrinolysis, and coagulation cascades, arachidonic acid release blockade, hence PGI2 decrease, and anti-cytokines action against interleukin-3, further going to placental cell apoptosis. So, character of pregnancy loss. How the loss appears. The typical presentation when the patient comes into a clinic, they either come with like growth retardation. We found growth retardation either clinically and then confirming later on by imaging, and may even cause fetal death in her second or early third trimester. So, whosoever patient is coming in her early second or third is having IUGR, growth restriction, or fetal death is suggestive of APLA or other, we actually need to work up such patients for APLA. Further, other immunological disorders like systemic lupus erythematosus, that high rate of RPL, and APLA 37% poor, which has very poor outcome, then which may be found to be associated or may not be associated with lupus flares, and even at times renal disease may be found or may not be found. So here comes a very important role of counseling, because such patients who come with recurrent pregnancy loss due to any reason, they are psychosocial, they are depressed. We need to we actually need to reinforce them in a positive way that actually makes difference. So coming to RAS, that's reproductive autoimmune failure syndrome, which cannot be detected by routine antibody estimate. But yes, it is one of the mentioned causes there. May I have next slide, please? Yeah, coming to management, workup, and besides workup and all, there is a great role of aspirin and low molecular weight heparin in our APLA patients, as my patient is more going in favor of APLA. And besides anti-paternal cell antibodies, then intravenous immunoglobulins, though not proven, but if we have offered everything, and those patients who can afford, we can go for IV intraglobulins. So aspirin in low doses like 75 ml low dose aspirin daily. Prednisolone 60 milligrams per day can be given usually in cases of lupus and all, but they do have their own side effects like cushingoid features, immunosuppressant, biliary tuberculosis, glucose intolerance, hypertension, growth restrictions. Heparin has got a very good role. It can be given as unfractionated heparin in doses of 5,000 international units subcutaneous, or it can be given in OD or BD doses, but it has some side effects as with like osteoporosis, thrombocytopenia, hemorrhage, and thereafter it comes low molecular weight heparin, which is more commonly given in comparison to heparin because it has got less side effects, and it can be given in doses of 40 to 60 milligrams subcutaneous OD to BD dosing. Role of intravenous immunoglobulin in RPL: 45% of miscarriages and 95% of late pregnancy losses from women experiencing RPL are chromosomally normal, and large data suggestive of causing being immunological. Immunotherapy, as I told, that the role is not very much proven, as there were HLA sharing and all were also found in husband and wife, but as such it's controversial, it's not very clear cut. So passive, it's given passive immunization with immunoglobulins, which actually causes down regulation of natural killer cells. That is, it alters the pro-inflammatory milieu, and that's how it helps in preventing the abortions. Intravenous immunoglobulin usually is given after more than or equal to 5 abortions, but in today's scenario, nobody waits for that much losses. So whenever we want to offer, we would like to offer them in the early period of gestation, early number of loss. Coming to defects in coagulation factors, there are not many coagulation factor defects. There are acquired thrombophilias and inherited thrombophilias. This is a slide which is showing various thrombophilias and with associated risks and the methods of testing. So factor 5, ladies deficiency, which has 3 to 8 folds risk of DVT and which can be tested by DNA analysis. Then factor 2, prothrombin mutation, that is 20210 gene mutation, which also has 3-fold increased risk of DVT and can be tested by DNA analysis. Then comes proteinase deficiency, showing 2-fold increased risk of DVT and which can be tested by activity assays. Antithrombin 3 deficiency having 25 to 50-fold risk of DVT. Then protein C deficiency, acquired activated protein C resistance, showing 1.7-fold risk, and which can be tested by anticoagulant response with activated protein C. Then methyl tetrahydrofolate reductase deficiency, which can be tested by fasting homocysteine if positive DNA testing, and then acquired hyperhomocystinemia. But yes, if it is present, then it should be corrected, because otherwise it may cause early losses and recurrent losses. Then treatment strategy, basically correction of hyperhomocystinemia, which I already told. Then low molecular weight heparin. Besides, we can add low molecular weight heparin in doses of 40 to 60 milligrams subcutaneous OD to BD doses, and low dose ecosprin in 75 mg daily. Either it can be started before conception, or it can be added once the patient conceives, and then it can be continued till 36 weeks of gestation. And low molecular weight heparin, we should always remember there are some patients who have inherited thrombophilias and they are already on warfarin, so we need to change them on heparin before 6 weeks period of gestation, 6 to 12 weeks, and even thereafter we can continue with heparin. And later on, post delivery, we can, after 12, like at 36 weeks, till like 12 hours before the delivery period, we have to stop low molecular weight heparin, and thereafter 12 hours post delivery, we need to restart them on low molecular weight heparin, or we can change to warfarin also.
Thank you, Dr. Kanika. Wonderful presentation you have done. You have covered whole AFLA, SLE, immunological disorders. What is the significance of torch? Nowadays, we do not have any significance of torch. I remember in our clinic 20 to 25, 30 years back, we used to give torchnil and all the medications. But now we are more towards low molecular weight heparin. That's what is the standard which is to be given. And as you said rightly, if it is more than 4 to 5 abortions, We do not wait for so many abortions to occur. And if they are affording, it's an expensive treatment, but there is some amount of stay for immunoglobulin therapy. So wonderful presentation done by you, and you have covered all the aspects about even coagulation defects and what is the mainstay treatment. So we will get back to you soon. I request now the next presenter, please be there present, and I want your guidance from the guest of honor and the chairpersons to be there with us. If anything is missed out, you can surely join in and give your comments. Dr. Nutan Upadhyay, please, I welcome you, and you can start reading your case presentation.
Greetings to all my seniors and teachers on this eve of Teachers' Day, and thank you, Bharti Maheshwari ma'am, for giving me this opportunity. Congratulations, Dr. Niranjan Chauhan, for conducting this webinar in such a nice and a smooth way. My case is a 35-year-old woman with history of three abortions. She has had previous 3 missed abortions, with the first one occurring at 8 weeks of gestation. The second abortion was at 7 weeks of gestation, and again this is a random combination that the third abortion was at 10 weeks of gestation. So there isn't any increasing, neither an increasing order neither a decreasing order. Next slide, please. So I think this is a case that is the most commonest group that we encounter in a day-to-day practice. Her hemogram was normal, her urine examination was normal, her LFT, RFT were normal, VDRL, HIV, the viral markers was all negative. The blood group was O positive, and husband had a B positive blood group. In her non-pregnant state, the D2 progesterone levels, when were done, they showed the value of 2 nanogram per ml, and again the progesterone levels were estimated on day 8, which was 8.7 nanogram per ml. Can I have the next slide, please? So, as per her evaluation before her next pregnancy, her endometrial biopsy was done, which was suggestive of which gave an impression of an endometrial lag of more than 3 days. The USG, which was done, was suggestive of lack of endometrial echogenicity on 7th post-ovulatory day, and luteinized unruptured follicle and luteal cyst formation. So these were the 2 features that were observed when her ovulation studies were done, that her endometrial thickness was not up to the mark on the 7th post-ovulatory day, and the copious luteum did not rupture at the proper time, and so we had a luteinized unruptured follicle, and which was converted into a cyst. Next slide, please. So the common things related to these cases are that what is the luteal phase defect, and what are the diagnostic criteria for the luteal phase defect, and do we empirically, that is, the progesterones and HCGs, are they which are being given, how justified are they, and other hormonal defects which may be associated along with this, which may be responsible for the recurrent pregnancy loss. So what is luteal phase defect? Let's come to the first question. And obviously, in this case, there may be more than one hormonal factors which may be working in conjunction and creating this disturbed milieu. So we'll go into each of them one by one. As is the conventional definition of LPD, that there is a lag of 2 days in histological development of the endometrium. So obviously we have come up with better ways of trying to find out the luteal phase defect. So when the mid luteal phase progesterone was done, that is approximately day 7 or day 8 post-ovulatory, it came to be less than 10 nanogram per ml. Although we know that maybe a single progesterone estimation may not give us the right idea, there are studies that say that when the values, they have to be taken consecutively, the values have to be pooled, and when we take the values together, maybe of 3 readings in the luteal phase, when the values of progesterone come more than 30 nanogram per ml, we that yes, there is adequate progesterone levels. But when we take a single recording of progesterone assay, we consider it to be, if it is less than 10 nanogram, we consider it to be insufficient. Abnormal expression of endometrial progesterone receptors or alpha VB3 integrin biomarker of uterine receptivity. As we know that the entire the window of the period of implantation, during the period of implantation, so if there is any disturbance in the morphology, which may be of the endometrium, which may be related to the luteal phase defect, so immunohistochemistry, so the assay of the endometrial proteins in the plasma and the uterine flushings, the cytokine expressions which occur in the endometrial cells, and the leukocyte population that exists. So all these things create a positive milieu for the implantation and the maintenance of the early pregnancy till the time that the placenta is developed and it's taken over. Next slide, please. So again, what is the cytokine milieu in the endometrial cavity, in endometrial lining of the patient? If the CD4 T cells, the helper cells 1 and the helper cell 2, the ratio is disturbed, because we know that the helper cell 1s create a more abortogenic milieu, and the helper cell 2 are the cells which give a better pro-pregnancy, pro-implantation milieu to the endometrial, which promote the implantation and the continuation of the pregnancy. Again, the progesterone-induced blocking factor, if this is lacking or is not insufficient, is not available sufficiently, this can again disturb the internal milieu. Again, there may be reduction of NK cells activity. In these NK cells are not the NK cells that we see in the plasma. There is a special colony of NK cells which are known as uterine NK cells, and by estimating the peripheral blood NK cells, we may not get an idea of the number of uterine NK cells which are there, and these NK cells have a very special role at the time of trophoblastic invasion of the stroma of the endometrium at the time of implantation. Next slide, please. So along with that, what were the hormonal assays that could give us a better idea whether the ovaries are functioning? So we have seen how the endometrium, what was the endometrial milieu in this patient. Now we are coming to the ovarian function, whether it is whether the patient is not going towards a diminished ovarian reserve, what is the ovarian function, what are the balance, and the what is the whether all the hormones that are there are in proper harmony or not. So if we are doing a day 3 FSH assay and we are finding the values of more than 20 international units, again it's a clear-cut pointer towards a diminished ovarian reserve, and we know that this is a patient who may not be having number of very good quality oocytes in her reserve. So the number is also decreased, and the quality of oocytes that the patient is having in her reserve is also not good. Again, if there is a low day 3 inhibin B, again this could also show be indicative of the low reserve, and again the pre-antral follicle recruitment and the growth of antral follicles may not be very good. Again, this can indicate the poor reserve in that patient. Low D3 estradiol level, if it's less than 20 picogram, I think this value has always to be taken in conjunction with the FSH values. If the estradiol levels alone may not be give a good indication of the the ovarian reserve of the patient. But yes, if we are correlated with the FSH values, will be better. It will be a better indicator. If the low D3 alone estradiol values, if you are taking it, if they are less than 20 picogram, again the number of follicles that we have and with the amount of estradiol they are producing is not adequate. But again, if there is a high FSH level, again it shows that there is the reserve is not adequate. Sir, again I still need the previous slide. Yeah. So coming to the antral follicle count, again which is done on the baseline scan. If it's again less than 5, even if the patient is young, we know that the reserve is less and the quality of oocytes that may be produced may also not be very good. Again, low anti-Mullerian hormone, less than 15 picomoles per ml. If we put it in our day-to-day values, if it is less than 1, and specifically if the AMH is less than 0.7, we know that the reserves have gone down drastically. Next slide, please, sir. Other than these, what are the other hormonal defects which can add to the disruptive milieu of RPL? Hypothyroidism. As such, there aren't any clear indications that hypothyroidism alone may be responsible for recurrent pregnancy losses. But if there is an untreated hypothyroidism, it surely will be detrimental to the growth of the pregnancy. We need sensitive TSH assays and even mild variation in the TSH values from the even if it is high normal, we may have to consider starting thyroxine. And we know that pregnancy itself causes is prone for autoimmune thyroiditis. So if the antibodies are rising, whether it is antimicrosomal or antithyroglobin, again they all are indicating an immunological reason for the prolonged hypothyroidism. So rule out hypothyroidism. As I have said, during pregnancy, for better maintenance of that pregnancy, a good control of thyroid status is a prerequisite. Again, coming to the next hormone, that is hyperprolactinemia. Again, if the prolactin levels are raised, the HPO axis is disturbed. There is insufficient folliculogenesis. There again, the oocyte maturation will also be hindered, and there will be more chances of luteal phase defect. So there is this has to be watched closely. Prolactin levels may not be the same in each assessment, so we may have to take more than one assays of prolactin levels, and if there are any of them comes disturbed, we may have to start our dopamine agonist treatments. Next slide, please. That is the bromocriptine or the cabergoline as per the age with which we are comfortable. Again, the insulin resistance, which may come in the form of pre-existing diabetes, gestational diabetes that develops during pregnancy, or the insulin resistance may be related to the PCOD condition that patient is already having. If it's a patient is already having diabetes, or she develops diabetes during, she is prone to gestational diabetes mellitus, we know that a pure glycemic control is a sure shot reason for increased teratogenicity and again increased abortions. PCOD, we know that hyperinsulinemia again will lead to, sir, I want to go back to the previous slide. So again, the hyperinsulinemia will lead to a cascade of events which can lead to not only the luteal phase defects, also poor endometrial milieu, which may lead to poor implantation also. So these are the combination of hormonal
Yes. Can you conclude now? I think that's you've done a wonderful job
Yes,
with
yes.
explaining all
Yes,
the
sir. That is
endocrine
what I want to say.
effects, the
So,
corpus luteal effect,
yeah,
insulin resistance, PCODs, diabetes mellitus, hyperprolactinemia, hypothyroidism, and all the important ovarian dysfunction and PCOS. I think you have covered wonderfully, and I appreciate the knowledge which you have shared today. It's not only just reading the slides, but your experience of more than 25 to 30 years of practice has also come into play. So, welcome. Thank you. We will get back to you soon.
thank you, sir. Yeah, thank you,
And I'm
sir.
sure there are many questions which are lined. I'll take all the questions at the end of it. I call upon Dr. Anshu Raina. She's from Greater Noida. Dr. Anshu, is she there? Can we have Dr. Anshu there? I think she has some emergency, so probably we will get back to her later. In the meantime, I would like to go to the next case. Just wait, please. Can I have Dr. Professor Samta Gupta?
Yes, sir.
Yeah, please go ahead. I hope you can see my slides.
No, sir, the screen is not visible.
Oh, just wait. Wait, madam, wait. Well, can you see now?
Yes, sir, I can see it.
Yeah, thank you. Welcome. Please go ahead.
Hello. So thanks, Bharti ma'am, for letting me to be a part of this excellent webinar and to share the platform with extremely learned teachers and academicians of Foxy. In fact, thank you, Niranjan sir, because as a panelist now you have made all of us the moderator from here. My case is a 20-year-old woman. She has been married since 6 years and she has approached to me to fertility clinic for secondary infertility. Now she had 4 abortions in the past. So now at this place, the important thing I would like to know from her from the history is that what was the period of gestation when she had abortions? So if it is in the early pregnancy, suppose it's a 6 weeks or 8 weeks pregnancy failure, then the causes would go in favor more of the genetic. Now, if my patient gives a history that her abortions had been in the late first trimester or in the second trimester, now the thing which is going to click in mind is that it could be a case of there is some kind of anatomic abnormalities. And we all know that in a recurrent pregnancy loss, these anatomic abnormalities, basically they have constitute at about 10 to 15%. So, and the prevalence of the congenital malformations is basically 7% is the prevalence of the congenital malformation. So, in this case, sir, can you go back to the previous slide? Sir, can you go back to the previous slide? So, the important thing this patient has done up with me is that she has already got a ultrasound done, which has shown a septate uterus. Now, when we look at the anatomic abnormalities, what we find that they can be either congenital anomalies or there can be the acquired abnormalities. In the congenital anomalies, the commonest ones are the septate uterus, unicornuate uterus, bicornuate uterus. So these are the commoner ones. And when we look at the acquired, it is mainly the endometrial polyp. Hello, sir. Sir, are you able to hear me? Because there is lot of disturbance.
Please mute.
Dr. Anshu, please mute.
Please mute the other panelist. Hinal, can you be the host and just mute?
Dr. Anshu, please mute your mic.
Yeah.
Yes, sir.
Beside the speaker, rest of all, please mute, because they have taken a lot of efforts to come today live to you and share their experience. They are not just here, just mere to read slides. So I request you, we will finish this case and we'll go back to Anshu Raina. I appreciate her dedication. She has an emergency, but she is still traveling in her car, and that is what is a dedicated Foxian. We will get back to her very much soon. We will finish this case of septate uterus. So I request Dr. Samta to please go ahead with the presentation. Thank you.
So what I was discussing was there are congenital and the acquired. In the acquired, there can be submucosal fibroids, and there can be endometrial polyps, which are the important ones, and the Asherman syndrome. Now, in my case, already she has been diagnosed with septate uterus ultrasound. But when it comes to diagnosis, one of the important, as per the X-ray guidelines 2017, the basic investigation tool should be the 3D ultrasound. So that is the take-home message, that the first modality of choice for delineating the congenital anomalies is the 3D ultrasound. The second choice of modality is a sonohistography. Then the third modality is our HSG. So it has been seen that with HSG you cannot basically see the outer contour of the uterus, and it is difficult to differentiate between the bicornuate uterus and the septate uterus. So the newer guidelines, what is the newer classification, how to differentiate between the septate uterus and the bicornuate uterus. So just in few words, if we draw an interosteal line between the two ostia and we look from fundus to that line, that is the myometrial thickness which is there. If that, and from there to the septum, if we look at the thickness, so we have two in between lines. If the interseptate line is more than 50% of the myometrial thickness, then that goes in favor of the septate uterus. And if we find indentation on the fundus of the uterus, that goes more in favor of the bicornuate uterus. So that is the way to distinguish. And regarding if still we have any problems, then obviously last resort can be there can be MRI. However, the hysteroscopy is the gold standard, because apart from the diagnosis, we can definitely do a definitive treatment while doing a hysteroscopy. So basically, when it comes to treatment, so now this patient has come up to me and we have been diagnosed that it is confirmed that it's a septum uterus. Now, next, what I would like to do. So as per all the guidelines and the available literature, I would like to do a septum resection in this case. So there have been different issues, because some of the guidelines say that there is insufficient evidence for the septum resection. However, the recent X-ray 2017 guidelines say that it's a condition, so it is better you go with the septal resection. And in this, there have been various studies and the analysis, and in one of the analysis, it was shown that with the septal resection, without a septal resection, the miscarriage rate was 44%, and after the septal resection, the live birth rate increased to 88%. So it's one of the very rewarding surgeries in this case. While doing a septal resection, the important things to be kept in mind is that you can go in with the unipolar or the bipolar. But when we are doing a septum resection, the important thing is that you should not go too far. So later on, it can lead to uterine ruptures can be there. And if possible, a diagnostic lab should be there while doing a septal resection. And the post-op management of the septal resection is also very important to prevent the readhesions. We should place a intrauterine contraceptive device at least for a minimum of 4 weeks, or we can, and along with it, we can put the patient on estrogen, that is estradiol valerate, 4 milligram to 6 milligram, and in the later half of the cycle, we can add a progesterone. So that is going to help in the regeneration of the endometrium. Apart from IUCD, we can also go in with a Foley's catheter that can be put in for the 10 days, but along with it, we will have to give, along with it, antibiotics need to be given. So the IUCD needs to be put for minimum of 4 weeks, and at least around 2 months of time is taken for the regeneration, and we can let the patient can go in for a repeat trying of the pregnancy after the septal resection. And regarding the Asherman syndrome, so the treatment is that we should do the adhesolysis, other congenital anomalies, bicornuate uterus. There are insufficient evidence that you should do any surgical treatment. Similarly, for the unicornuate uterus, there is there should be no corrective surgery should not be done. So it is mainly for the septate uterus we have to do this. The septal resection needs to be done for the correction of the anatomical abnormality.
Madam, wonderful presentation. I want to ask just one question here. What will be the distension medium you will be using for the uterine septum resection?
So that is going to
be the flow. What will be the flow of the distension medium? How much ml should go at one go to remove the septum? And fourth question is, which would be a better instrument to cut the septum? Whether it will be a cold knife, whether it should be done with a scissor, or whether it should be just done with any other modality like laser or something?
Sir, the distension medium is going to depend upon the whether we are using the unipolar or the bipolar. So that's going to decide upon what is the distension medium. Sir, I cannot comment a lot on the flow rate because I am not a very experienced hysteroscopic surgeon, so I cannot exactly comment upon the flow rate.
Okay.
And then regarding it
But
would
we are
be
more
better
worried that it should not be more than 1.5 to 2 liters which goes inside, because that might cause electrolyte acid imbalance.
imbalance.
They're more worried about.
And the important thing is we should not do the basic thing. What we need as a surgeon when we are starting is that we should not overcut the septum, because that's going to lead to myometrial weakness, and later on if the patient conceives, that it can lead to uterine rupture. So under treatment would be a better option in comparison to the over treatment. So that is one of the important things we should keep in mind while we are doing a septal resection.
Wonderful. Dr. Samta Gupta, you have given out the latest guidelines of X-ray, and the way you have presented also the use of IUCD or Foley's catheter, or you can just give estrogen and then we go ahead with planning with ovulation induction, maybe a normal conception, and then go ahead. But it's better to go ahead with an IUI or an ICSI if the facilities are available and the patient is affording. Now I would like to call upon Dr. Anshu Raina, and she is a very dedicated Foxian and coming as a secretary of the Noida Society, and it's she has an emergency, but I told her I'm not going to leave you, and that's what we are having the dedication here. Dr. Anshu, I don't want to waste much of your time before you reach to your
Good evening,
destination.
sir. Thank you for giving me the opportunity. And my case, a 22-year-old female, who is presented with a pain in lower abdomen, at the right, mainly on the right side of the pelvis, and during periods. Her periods was early and the profuse with the pain in the lower abdomen, which goes to the back. Feeling of excessive heaviness in the uterine region, and the patient has 3 abortions earlier between third to 6 months of the pregnancy. This is the case. And next slide, please. So this is diagnostic approach and management. USG showed posterior wall fibroid, that is a 4 into 6 into 5 centimeter size in dimension. Next slide, please.
Madam, now this is the posterior wall fibroid, and she's a case of an RPL.
I'm audible?
Yes, you are wonderfully audible, and we appreciate your dynamism and the way you are going ahead for your case. So this is the posterior wall fibroid. Would you like to touch it or refer her to a laparoscopist, or you would like to yourself?
Sir, you're not audible, sir.
Can you hear me now? Hello, can you hear me? Can anyone tell me, apart from Dr. Anshu, that whether I'm audible or no?
Yes, sir, you are audible.
Yeah, so I think we have lost some connection probably with Anshu. This is a case of posterior wall fibroid. If she gets back, we will surely listen to her, what she has to say. But it was a wonderful way of connecting with her. I think she's still there.
Hi, sir.
Yes. Can you hear me? You please go ahead. We would like to go ahead with a myomectomy and we want to hear your voice. So this is what we did, a histoscopy. Histoscopy looks normal. There is the cornea which is seen, and we did a chromopertubation. The right tube is fine. The left tube is fine. We can see the methylene blue coming inside. We have done hysteroscopy. That is the fluid in the hysteroscopy. In the pouch of the
Sorry
Douglas,
to
we have
interrupt you,
removed.
sir. Your voice is not audible.
Yeah, but I can, don't worry, I'm taking over now. Don't worry, there's nothing to worry. Your presence is more important. So we're given a pitricine, we dilute the 1 ampule of pitricine with saline, and we have to see that there is no bradycardia being seen there. We are using here harmonic. The idea is to cut open the serosa and approach the posterior wall. And we slice off away and enucleate, totally remove out the capsule. Then we use the myoma screw, and once that is inserted with counter traction and traction with a grasper, we take out the fibroid, and this is how we reach the base. At the base, we have to see that coagulation is done properly. There is no amount of bleeding which is kept there. We have to achieve proper hemostasis, otherwise the dead space has got a hematoma, and that's what we don't want. So we try to see that the base is totally cut off and it is coagulated, hemostasis is achieved. After this, the fibroid is sparked out. Then we check out that the uterine cavity is not opened, everything is fine. Then we have to suture now. This is the barb sutures. We go slowly. We start from below and come upwards, and we go on suturing till we come to the serosa level. Then we put on the baseball sutures. So we have near, far, and far near sutures. The whole idea is that we are going to take thick bites, and when we take the thick bites, we are going to obliterate the dead space. And that's the reason we do it in such a way, take big bites, and barb sutures, the spicules, you do not have to tighten, it gets locked itself. I hope you can hear me now. So this is how you go on obliterating the dead space, and I hope you are enjoying the video. Once this is done, we have to now see that there are no adhesion formation, the blood loss is done, the myoma is now to be morcellated. This can be done endobag morcellation, or we can go ahead and do a morcellation like this, but we have to be very careful. We use a simple gloves also, and we can morcellate it out, cut into with a knife, and once that has been done, this is interseed. We introduce it inside and cover it so that it doesn't cause any addition. We don't want any omentum or intestines to come there and get stuck up. The whole idea is that it doesn't turn black. Achieve proper hemostasis, give a good lavage, confirm that there is no bleeding, check the pulse and blood pressure of the patient, and you come out, remove the ports, remove the CO2 gas. I think I have done the job of Dr. Anshu. Thank you so much. You want to say something, Anshu? Dr. Anshu. I think we have still lost the contact, but we'll get back to her soon. Now I call upon the next speaker, Dr. Sonal Agarwal. Madam, please come and join. I hope you can hear my voice.
Yes, sir. Good evening, sir. Thank you, sir, and thank you, sir, and Bharti ma'am for giving me this opportunity to be the panelist. I'm extending my warm welcome from Mathura Obs and Gynae Society. So I'll be discussing the last case, that is the case of one of the causes of recurrent pregnancy loss is incompetent cervix. Now the causes of the incompetent cervix are, it could be acquired or congenital. The congenital one includes the uterine malformations like the Mullerian defects, which could be, as discussed, bicornuate uterus, separate uterus, or the unicornate uterus, or it could be some connective tissue disorder like Marfan syndrome and Ehlers-Danlos syndrome. And the acquired causes are cervical lacerations during the previous vaginal birth, or it could be the forced dilatation of the cervix, and it could be some cone procedures done on the cervix like cone biopsy or the Lee procedure. Now, how do we diagnose the cases of cervical incompetence? It could be history indicated. Can we go back to the previous slide? Yeah, it could be history indicated, like the history of repeated second trimester losses or the preterm birth, painless cervical dilatation, and the precipitate labor. It could be ultrasound indicated, like cervical length is less than 15 millimeter, and the cervical length reduction is 1 millimeter per week. Lastly, we can diagnose by the physical examination, like the shortening of the cervix, which is detected on the manual examination in the second trimester. So next slide. Next. Dr. Shirodkar once said that for circulage, the woman circulage should be done in the woman who has the history of repeated abortions between 4th and 7th month, where one can, by repeated internal examination, find that the cervix is gradually yielding. Next slide, sir. Hello. Now, as we are evolving every day, the nomenclature for the circulage has also evolved. Initially, the old nomenclature was prophylactic or elective, therapeutic or salvage, rescue or the urgent one. But now, the new nomenclature includes the history-based history indicated circulage, which is done at near about 12 to 14 weeks. Then the ultrasound indicated circulage, which is done during the second trimester ultrasound, and the third one includes the physical examination based circulage which are being done, and the combined or the ones like where the previous failed vaginal circulage has taken place, so we can go for the abdominal circulage. So next slide. So we conclude that circulage is beneficial in the patients who have got 2 or more second trimester losses. It is beneficial in the patients who have got the cervical length of less than 15 millimeter or the internal os opening of more than 5 millimeter. And it is not useful for the patients who have multiple pregnancies or have the history of placenta previa, who are bleeding or thank you, sir.
What are the different types of circulages, madam? Please elaborate. We are not just reading slides. We want inputs from you, please.
Sir, the different type of circulage are, we have a Shirodkar circulage, we have McDonald circulage, we have the Warren circulage, we have Epsinus Flores circulage, and then we have got the abdominal circulage. In Shirodkar circulage, what we do is we take the stitches at the level of the internal os. We mobilize the bladder from the anterior wall of the cervix, and then place the suture as close to the internal os. And after that, the bladder is the vaginal wall is being put back on the anterior wall of the cervix. In McDonald's suture, we take a pursing suture on the 4 quadrants of the cervix, and it is again as close as to the internal os, but here the bladder is not being mobilized. Then we come to the Warren suture. Here 2 sutures are taken. First from 6 o'clock to the 12 o'clock position, which is tied anteriorly, and then from 3 o'clock to 9 o'clock position, and which is transversely tied. So then one is the abdominal circulage, where there is a recurrent history of vaginal circulage failure, where it can be done laparoscopically or by a simple phalansteal incision. A laparotomy is performed, and the cervical incision and the circulage is given at the cervico-isthmus junction of the uterus. And here the patient is already being planned for a cesarean section, so here the normal deliveries are not being conducted.
So I think wonderful explanation by you, doctors. There are different types of circulages which are done. What do you feel about emergency circulage? Is it better than elective?
So emergency circulage, they are also called rescue circulage. They can delay the delivery by 5 weeks, and definitely they are of some help. They can also help in the steroid coverage to the fetus, and the neonatal outcome will be better.
Well, thank you so much. It was wonderful of having you all. We got questions. I want to tell more than 650 members have logged in and are seeing you live rather. So it's amazing to have all of you here. I'm going to stop sharing here, and we have few questions we will be asking. It's not some exam, but wonderful. I would like to thank all of you. Amazing. The way of knowledge, the amount of knowledge which you have given to us is so good, and everybody is appreciating that knowledge, and all of you have done such a wonderful job. But I want to come back to the chairpersons and other luminaries who have joined us to please put their inputs here and guide us if we have missed out something.
Dr. Dr.
Yes, madam.
Chavan, it was a very nice program. Every speaker has given a very informative and the detailed information about the cases and the cause of the recurrent loss. In our days, we used to encirclize at the 12, 14 weeks or 15 weeks when there was a history of repeated abortion. That was an elective. We used to wait for emergency, because emergency, then you become nervous and the complication can occur. The second thing is that she mentioned in recurrent abortion as a use of this I think progesterone with the corticosteroid, that is 60 milligram prednisolone. I don't agree with that. In all the cases of 60 milligram of prednisolone is to be given. That is my view. I don't know what is the view of you or others, but that is my view. And it was a very well presentation. Even all the panelists, they have taken all the.
Yes, madam. Thank you. Dr. Neeta Mehra, would you like to say something here?
The MD examination, we used to prepare the preparation for the examination, because every day we are listening the webinars, and that is adding to our knowledge.
Yes,
so we are generally becoming more and more intelligent these days.
After MD, our postgraduate examination, this COVID has taken us back to school.
Yes, it appears, because daily we are doing this, and it just gave a remembrance of our olden days. That's all.
Yes, Dr. Neeta.
Yes, thank you very much for such informative talk, and all the speakers were thoroughly prepared, and they have given us such large, so much of knowledge about every topic, and in a very interesting way. Actually, presenting cases and discussing them is more beneficial to everyone. So I found it very nice, and thank you very much for organizing this webinar.
Wonderful. It is my honor that
one thing is more. One thing is more, that torch is not required in all the patients nowadays.
Yes.
And if it is there, yes, because it is a cause of the second trimester. So that is no big importance in doing that test. And if we are not using the other drugs except the low molecular heparin, that to be is given very carefully, that is 40 milligrams subcutaneously. And we have to monitor the patient, seeing the coagulation status.
Thank you, Rukma madam, and thank you, Dr. Niranjan, and very beautiful, in fact, panel discussion. And you have designed the panel in very beautiful way, and all participants have presented well. Professor Shikha Singh from Agra Medical College, you want to add something? Dr. Sarita Gupta, if you want to add something, or any special guest or anyone want to add something. Dr. Sharda Sarup, you can unmute yourself. So I think
well, it's an amazing thank you, Dr. Bharti.
Very well presented.
Dr.
Today
Sarita
was a
Gupta,
very
madam,
good
would you like to say something?
I would,
Sarita, madam, please unmute.
Niranjan, I would like to say,
Actually, Dr. Chavan and Bharti, you have taken a lot of pains in.
Thank you, madam. आपका आना and stay करना इतनी देर तक is very pleasure for us. Yes,
Madam, we are going to come back. We are going to come back after 15 days with one more big program. This is just the beginning.
We are ready to listen that. We are prepared to listen that.
Thank you, madam.
Yes. We will come with something different, something. What would you like to have? Endometriosis? We can do that.
Yes, that will be interesting.
You do something you was asking.
Yes, Dr. Sarita wants to speak something. I think Dr. Sarita would like to speak. I request you to please unmute. Dr. Sarita, you will have to unmute your mic.
Shikha, you have to unmute. Those, Dr. Manpreet.
Am I audible now?
Yeah,
Am I audible now?
Yes, yes.
Ma'am, you are. Yes?
Yes,
Yeah.
one-liner, please, one-liner, because we are going to close this at 8:30 sharp.
Thank you, sir.
It's an
Thank you, sir,
amazing
for
2.5 hours we have been interacting with each other. Please go ahead.
Thank you, sir, for calling all of us. And we like to have medical management on fibroids further.
Yes, we will do that. Thank you.
That will be more beneficial regarding injection and all.
Yes.
Hormonal.
Okay,
Yes.
Manpreet, Dr.
Yes, Manpreet. Angita Singh,
Hello.
please.
Yeah.
That itself
Yeah.
is a very large issue.
Thank you, madam.
Hello. Yeah,
Medical management.
I could not attend completely because I had my OPD. So I just came right now.
Okay, thank you. And yeah, and thank you for your
first half.
of the society. Yeah.
I would like to add that these patients of recurrent pregnancy loss, they usually are psychologically
Please kindly tell your name and then talk because we can't understand who is talking when. So that would
This
be
is
a nice
Dr. Kanika,
Yeah.
Dr. Kanika Singh from Meerut. Well, I
Yes.
just would like to add that all these patients of recurrent pregnancy loss are psychologically disturbed. They are in a very depressive state because of 2, 3, 4 recurrent losses. So it's a duty to have a tender, loving care. We should be very supportive. We should make them very positive. Though we should show them the real picture, but we should be very supportive. Being a doctor.
Okay, next is Anurita Singh. Please raise your hand if you want to say something so that I can make out. Anurita, please go ahead.
Yes, as Kanika said, in spite of being a very important health issue, RPL, it is very disheartening for the patient. And if we don't find the cause at the right time, it is disheartening for the doctor also. So we have all these RCOG, ASRM, and ESHRE guidelines for the treatment and management of recurrent pregnancy losses. So we need to follow it perfectly so that we can give benefit to the patient.
Yes. Thank you so much. Now I'll take few questions, and I know all of you know what you have presented, and I know. So I'm just going to read question. The guy who has presented and the madam who has presented, I would like to correct myself. Please take that question. It is pertaining to you. This is before that I would like to say congratulatory messages. I would like to read them. Greetings from Saharanpur Obstetrics and Gynec Society. The president wants to thank all of you and allowing herself to be here in the part of this esteemed panel. Amazing. There are many congratulatory messages from Mathura, from Agra, from Saharanpur. Lovely webinar. Congrats to all participants. Congrats to Dr. Niranjan. This is Yamuna Nagar. And there are many of us have, they have been seeing us, more than 650. Dr. Rishika, Muzaffar Nagar, excellent presentation. And there are a few more. So I would like to take these questions from Dr. Lata Shukla from Mathura. Can ecosprin be given conventionally to all these patients who are having more than 3 abortions? Anyone can take this who is an expert who has taken that case.
Can I take it?
Yeah, please. It is your case. You please take, please.
No, sir, it was not my pick. But yes, low molecular weight, aspirin can be started if there is no cause found and it's unexplained and more than 3 recurrent pregnancy losses. Yes, we can start the prophylactic aspirin can be started in the dose of 150 milligram. Even preconceptually, we can definitely start aspirin in these patients. And then later on,
lecture you mentioned 75 milligram.
But ma'am, some of the recent guidelines say, yeah, ma'am, 150 milligram should be started.
Yes, you are very right.
Please raise your hand or introduce your name and then talk.
This is Dr. Kanika. Yes, low dose aspirin can be started preconceptionally and can be increased to doses of 150 milligrams as per latest guidelines.
Well, the next question is from Dr. Rekha Agra. Can aspirin be given in thrombophilias? Yes, please take Dr. Kanika.
Yes, it can. Yeah, am I audible?
Yes, you're all.
Yes, it can be safely given. It is actually supposed to be given.
Yeah, be precise and to the point. Thank you so much. Dr. Alpana Agarwal from Bareilly says, great organizer, great panelist, amazing discussion which has been going on. And this is Dr. Archana Mehta from Greater Noida. Advantages of microarray over traditional karyotyping, role of microarray in stillbirth. This is, I think, to the first case
Yeah, sir, I would like to answer this question because this is the latest thing which has come up, and we've been following this schedule. Like a microarray has to be done for the conceptus, which with the previous recurrent pregnancy losses, and this also, if the present pregnancy she has miscarried and we have the fetus of the conceptus, so we going for the that is the significant form of microarray. And why it is better than karyotype? Because the reason it has a better resolution, so it gives better result. The result is better, like it is more than 90% of the cases it can diagnose the chromosomal abnormalities, which we have already mentioned. There's a list of the chromosomal abnormalities. It can pick the parental
Yeah.
Dr. Niranjan, can I just add to this?
Your mic, host, please unmute your mic. Sorry, mute your mic.
Dr. Niranjan, can I just add a point to this?
So it has a better resolution. It can pick the parental origin of the aneuploidy, and because we use the technique of biometric evolution, so the errors which come up with microarray are very, very less. And one more important thing to add on to it is that the maternal contamination is ruled out with this. It helps us with this thing. And also the result which is obtained with the microarray is within a week, like 7 to 10 days, at the most 10 days we get the result, whereas with karyotyping, it is up to 21 days we are not able to get the results. The last thing is it is very cost effective. So that is the reason we go in for, actually it has all the benefits over the karyotyping. Rather the karyotyping, with the evolution we evolved to fish, but now it is karyotyping, and in a year or two there are certain studies which are going on for the further testing management or for the cytogenetic test. It is still in the process, and it is going to take 2 more years to come up, and in future.
Yes, madam. Yes, madam. Thank you so much. This is to Dr. Bharti.
Dr. Niranjan.
Yes,
Dr. Niranjan, can I just add a point to this?
Yes, Dr.
Can I just add a point to this? For the practical use, just like especially,
I think
a point for this. Microarray test is being done in 2 things, 2 groups. In the lower cost version, the 5 major anomalies are being picked up. So supposing the 5 major ones, just like the trisomy 13, the Patau syndrome, and all these trisomy 21, there is a 2 package that the laboratories are offering. In the one, there is just 5 of them that are picked up, which is a cheaper version. And when we are doing the entire the chromosomal analysis, it is coming out to be the double. So for the knowledge of the private practitioners, if the cost is a big factor, we can advise for microarray of the major 5 or 6 anomalies that we encounter. That is a cheaper version of it. So some laboratories are offering it as 2 options.
Thank you. Thank you, Dr. Nutan. Yes, Dr. Niranjan.
Yeah, madam. The next question is to Dr. Bharti. This is from Dr. Gayatri Rathod from Pusad. So Maharashtra is watching you, madam. What is the dose of anti-D in 2nd trimester abortion?
300 microgram. It is always up to 12 weeks. It is always full dose, 300
So dose is always a fixed dose. That is 350. We should not compromise with the dose.
Before 12 weeks, nowadays it
even
is
in 2nd trimester.
Okay.
That is my opinion.
Yeah. Dr. Shriji is also asking, Dr. Bharti, this question is for you. If I am giving anti-D prophylaxis at 28 weeks, still postpartum prophylaxis is required?
Yes, definitely it is required.
I think Dr. Shriji, Dr. Bharti has answered this question. Yes. Ratna Sharma from Agra, please tell the dose of prednisolone in SLE.
Who has covered SLE?
Patient with pregnancy with SLE, what is the dose of prednisolone?
It is not... Anyone
it is 60 milligrams only, but it should be avoided because it has some side effects.
Who is this? Please.
This is Dr. Kanika, sir. Yeah. It is given in the same dose of 60 milligrams as I mentioned. Studies have written.
Yeah, madam, I am asking this because I am reading chat, and when I am reading chat, I can't see who is talking.
Okay.
Okay.
This
So there
is
are some
Dr.
12 people who
Kanika.
are sitting in front of me, and I
I'm
had to
sorry.
read chats and I had to just try to understand. That is the skill of a moderator. And I thank Dr. S.J. Sethi, Dehradun. Dr. Niranjan, you are excellent. Want to know? I am excellent. I am knowing. Thank you so much for those compliments. But she is asking a question. I want to know if a non-immunized bleed in the first trimester, should she be given anti-D and how much? I think
If
this answers.
Yeah, if there is non-immunized and if she bleeds, of course, it should be given 300 micrograms. Only
Okay.
The
below
dose
12
is
weeks
always the
trimester.
same.
Yes.
Okay, yeah.
Yes. Okay,
We should
beautiful
not compromise with the
presentation.
dose.
Beautiful presentation indeed. Congratulations, Dr. Bharti. Well done. This is Dr. Meenakshi from Aligarh.
Thank you. And thank you, Meenakshi, for keeping your society. In fact, Dr. Niranjan, I must share that once you have said, and it is really difficult, but I have left only one message that I want to have this program, Matlab Dr. Niranjan and this MDP committees. All societies of EBSM, Meenakshi is the secretary of Aligarh Society. So actually, they all have postponed their programs and all they have given consent for this particular day. And they all are managing by anyhow to organize this program in their society. So I am really very much grateful to all of you that you have organized this program. Thank you.
So I am also very grateful to all of you. Let's come back to the questions now. From Yamuna Nagar, Dr. Sunita Swarup. Can a RH negative primary with uncomplicated pregnancy, can I have high drops antenatally? No history of any antenatal bleed, etc.
Actually, what is the name of that audience? But I want to tell you that sometimes there is no active history, like patient has not delivered and there is no present or obvious history of sensitization. But there is some sensitization. Without sensitization, there could not be incompatibility. But sometimes it is not obvious. But normally it is not usual. You have to take detailed history. Even if incompatible blood transfusion and any other in the past, that was the cause of sensitization. There are
I
other
think
causes of hydrocephalus, that is different thing, that parvovirus and another thing that you have to rule out. Only on ultrasound by hydrocephalus you can't say.
Okay, guys, we have just got 4 minutes, and I want one liner from each panelist, and then we close.
Dr. Nutan, I want one line. Dr. Nutan, Dr. Samta, Dr. Ruchi, Dr. Kanika, or
Yes.
more. Excellent presentation. I'm really proud of you.
Thank you, ma'am.
I have
Thank you, ma'am.
been a panelist. I'm really
Thank
proud
you.
of you and Samta and all. Thank you very much.
Yeah, thank you. Next.
Thank you.
You have already presented very well.
Chalo, jaldi bolo. One liner regarding RPL.
Okay, I'll wind up my in
Dr.
one
Ruchi
my
Srivastav, we
liner.
start with Dr.
That-
Ruchi. Yeah. One liner, huh? Not paragraph.
Hello, thank you. Love you.
Hey, not only 2 words, huh? It's regarding RPL. You had your case, so you can just talk about your case. I want one liner from each panelist, please. I think you have to unmute yourself, Dr. Ruchi.
Unmute yourself.
You have to unmute yourself.
And Dr. Sonal, you have also done very well. Yeah.
Thank you, ma'am. Thank you.
I have actually read all.
Yes, Dr. Ruchi, just one liner regarding your case.
So a proper history has to be taken, and a family history has to be taken definitely,
Okay, well,
because
thank
we
you.
have to include the genetic disorder, and in that we have to ask the infertility cases. If there is infertility in the family, a recurrent pregnancy loss in the family, or any any defect in the child who's born earlier, or
Yes.
any mental disorders.
Not any congenital anomalies in the past history, family, fine, thank you. Dr. Nutan, one liner.
My one liner is that yes,
I'm sorry
there
to
can
interrupt
be
you.
many
I'm
types.
really sorry to interrupt you. Please go ahead.
Okay. My one liner is that there may be more than one coexisting causes. So even if we find a uterine septum, we shouldn't forget the endocrinal assessment of the patient, because the good control of TSH, good prolactin management, good glucose levels, managing good glucose levels, and giving good progesterone support along with tender loving care. I
Yeah,
suppose
very good.
the patient will be able to walk off till her 9th month. So
Dr. Kanika.
full term with all our wishes.
Dr. Kanika, your tender love caring has been taken by Nutan, so you don't have anything to say now.
No, I'll say I have to take a detailed history of my patient, good physical examination, supplemented with good workup and right information to the patient and right guidance along with full support.
Okay.
Thank you.
Dr. Samta Gupta.
So for all the anatomical abnormalities, a 3D ultrasound is the best modalities, and second is the SSG. And regarding some mucosal fibroids, hysteroscopic myomectomy, I would like to say that only in the lesions which distort the uterine cavity, in those it should be done, and not in each and every fibroid. A hysteroscopic myomectomy should be done for a RPL case.
Okay. Anything? Now next, Dr. Sonal.
I would like to say that rescue circular should be done. It should not be avoided because it definitely gives time to prolong the pregnancy for at least 5 weeks, and it definitely gives time for the steroid coverage.
Okay, Dr. Andurita.
What can I say, Niranjan?
Madam, you are the chairperson. You are the boss.
It's a beautifully arranged webinar. Dr. Bharti spoke very well. I mean, it was such a vast topic, but she concised it and spoke so well. And the panelists, I'm surprised, all of them spoke so beautifully in detail. Lovely it is. And definitely you'll be, as you told, we'll be meeting again. So that's a promise, Niranjan.
Thank you, Anurita, Kanika, Bharti, Ruchi, Nutan, Samta, Neeta Mehra, Sonal, Manpreet, and everyone who joined us today. Before I end today, I have to read this for all of you. Since I am standing for election in IAG, I am your treasurer. I am your treasurer post candidate. Vote for me only if you find me worthy. Okay? Please know me, and check my word the same. But this is what I have to say. वोट डालने चलो रे साथी, लोकतंत्र के बनो बाराती, एक वोट से करो बदलाव, नेताजी के बदलो हाव भाव. We are not Netajis, we are representing Foxys and other organizations, or all the leaders of all those organizations. सही उम्मीदवार का करो चुनाव, बेमानियों को मत दो भाव. आपका वोट है आपका ताकत, लोकतंत्र की है ये लागत. So it's very important that who you choose and who represents you. With this, I would like to thank all of you, 650 people logged in, and we will join you soon, very soon. Shaba Khair, Shubh Ratri, Khuda Hafiz, फिर मिलेंगे. नमस्कार.
Thank you.
Thank you so much, sir. Thank you, ma'am.
And best wishes to you. Thank you.
Thank you, Madam Bharti. Will join again. Thank you all.
Yeah, sure.
Thank you, Dr. Bharti, once again. Namaskar and good night.
Namaskar, and we will meet again soon. Bye.
Thank you, doctors. Thank you, Dr.
Thanks, ma'am.
Thank you. Bye, everyone.